All right, apologies, guys. So, just a little housekeeping before we start. We encourage you, if it is that you have not yet paid for the CEUs, we have the banking information posted. It's $1,000 if you're a non-member, and just send a receipt to the email once you've done so. All right. And I'll be sharing a form with you in a little bit, and I'll encourage you to fill it out once the seminar has ended. All right, I'm gonna hand over to Marshall to have her introduce our first speaker. And just a note, if you have any questions, feel free to put it in the chat, or if you want to message me privately, you can do so as well. Thank you.
Good afternoon again, everyone. Sorry again for the technical difficulties. This is our first, and we're just trying to get everything together. So let me begin by introducing our very good afternoon again, everyone. Um, Sorry again for the technical difficulties. This is our first, and we're just trying to get everything together. So let me begin by introducing our very good afternoon again, everyone. All right. I'm sorry about that. We're also streaming live on YouTube, and I think there is some feedback from the YouTube channel. All right, so let me begin by introducing our very first speaker and my very good friend, right, Dr. Sorry about that. We're also streaming live on YouTube, and I think there is some feedback from the YouTube channel. All right, so let me begin by introducing our very first speaker and my very good friend, right, Dr. Sorry about that. We're also streaming live on YouTube channel. I'm really sorry about that. I'm just trying to make sure there's no feedback now. Can you put an emoji or a thumbs up in the chat if you're no longer hearing the feedback, but you're still hearing me clearly? I'm really sorry about that. No, it's just trying to make sure there's no feedback now. Can you put an emoji or a thumbs up in the chat if you're no longer hearing the feedback, but you're still hearing me clearly? I'm really sorry about that.
Good afternoon, Marcia. There's a delay in the there's a repeat, so you're still getting the feedback, but it's delayed. It means that you have to mute the Zoom cannot be on with the YouTube with the same computer.
Yes, I do apologize. I was just trying to close it out.
Yeah.
Trying to hear if I'm getting that feedback because I closed all my Google Chrome. I'm not hearing it now. So let's hope that I've closed all windows finally.
All right. Sounds good so far.
Yeah. All right. So let us begin again. My apologies. We did have some technical challenges, but I think we're finally here. All right, so let me begin. So I'd like to thank Dr. Pollyanna Howell Chang for agreeing to be a part of our webinar today. She is my very good friend and presently serves as the clinical head of pain management at Kingston Public Hospital. Along with a team of physicians and nurses, she manages a diverse group of chronic pain conditions. She has 15 years of experience and is a graduate of the UE and the DM program in anesthesia and intensive care. She also had training at the Cardiff University, where she received her master's in clinical pain management. Her research interests include the management of chronic pain in lower socioeconomic areas, the impact of nutrition in the management of chronic pain, and is a vocal advocate of the importance of physiotherapy. So you can see why she had to be included in this panel. Welcome, Dr. Chang.
Good afternoon, everybody. Thank you very much. I am very, very happy to be here. Thank you so much. I'm going to try to get through the technical things that would help me to present and get going. But I can do a little bit of what you call it there now, a little bit of housekeeping for myself. I just want you to give me your feedback. Are you seeing my screen clearly? Yes, may I have some feedback? Are you seeing it?
Yes, you are seeing it very clearly.
Okay, great, wonderful.
Yes.
So, all right, great. Let's get going. Thanks again to the JASM. Thank you for allowing me to come and present. And I'm always happy to talk about pain, and I am looking forward to particularly the presentations that are to come, because I am quite impressed with the lineup that you have today. And so I'm encouraging those of you who decided to join, thank you so much for taking your time to just get locked in, because these presenters I am looking forward to. Certainly, Dr. Paula Dawson doesn't require any introductions, but I am looking forward to hearing as well Mr. Nicholas Powell and Alison Taylor, who come with a wealth of knowledge and information, and also hearing from you. So, housekeeping matters. Continuing, I am going to be using a platform where I'm using Mentimeter. And for those who don't know, I am going to ask, it allows for engagement of you, the audience, because of the 60 odd of us or 80 odd of us that are on, I am sure that there are some that are quite versed in pain management and have a lot to contribute. And I think that we can benefit from this collaborative approach. And so when prompted, there will be a code and a QR, and you try to, let me see if you can see that. We want to get that out of the way first. Well, let me get the QR. Are you seeing a QR here? Code on the screen?
Yes, we are.
All right, and I think it was also included in the chat. And so at the appropriate time, those who wish to, please engage it. We don't take any identifiable marks from you, and so we won't know who is responding, but it certainly helps to give a more robust discussion to what I'm talking about. And then my other sort of disclaimer or housekeeping is, I am not a sports medicine physician. I am not an athlete, but I have been overcome by needing to use a lot of sports analogies. So I beg your pardon as I do that. And my first one, I am therefore going to be starting off the innings. And we're going to be talking about the pain interview, how we are enhancing communication so that we can understand the story behind the pain. And I am going to be using some terms that I have learned, and in the process of researching for this presentation, I garnered a lot of information. And that's one of the reasons why I am particularly interested in doing things like this, because you're always learning. There's so much depth of knowledge out there. And I certainly am not the repository of anything with respect to pain, and I'm looking forward to contributions from you. So when I am going to be using the terms athlete, I had a discussion and a conversation with Don Anderson. And for those who don't know, he has over 40 years of service to sports administration at the highest level, national level, former president of the Jamaica Olympic Association. And so he is very well poised to give me some guidance as to what the structure of sports medicine and athletes and how the athletes are treated with respect to their medical care. And in our discussions, he gave me the guidance that certainly the athlete is anybody that is skilled in physical training, eh? And of course, we know that that runs a wide gamut. You have athletes that are junior level, which usually describes those that are at the level or at the age of 10 to 14. And those pundits and the purists can correct me for those areas that I'm not accurate on. And then you have the elite athlete, that is the one that is usually at the national level, that may be going after medals, medal contenders, and those are usually the ones that are at the highest level. Now, you can understand the research suggests that there's the 18-year-old or 18 age is the average age of an athlete, but we have as young as 10, and then we have certainly those in the 20s. Merlin Otti remains an enigma, and so she's a little bit older than normal. So we're focusing on certainly 10 to early 20s as the young athlete, and that spans a gamut in terms of the psychosocial maturity level, cognitive level, and I want you to keep that in mind as we are continuing this discussion. How can we decipher the hurt? How can we have a more collaborative, integrative pain response to these persons, to these athletes as they span the range? So let's get going. So the pain interview, and I'm going to ask you to look at the QR code, and it's also in the chat, I believe. And how often do you assess pain in athletes? So there are several of us on today. I have 88, and as I said, you span the gamut of experience, knowledge, and wisdom. Not all are physicians, not all are physiotherapists, but how often do you assess pain? And assess pain does not mean, and certainly what is assessing pain to you? How often do you find out about pain? And I'll just give you 20 seconds to put those in, those who wish to comment. And certainly, thank you. I'm seeing often and I'm seeing always, right? I'll give you a little bit more time to do that. And we're talking about, I just want to get a feel of what is the assessment level in my audience. Who am I speaking with, and how often are you assessing? All right. You can continue to do that if you so desire. We're going to give a little time because I really want to benefit from your knowledge, wisdom, and experience, because you'll find that what we're going to do, we're going to be talking about a collaborative approach a lot. All right, so I'll just take the responses. So we have 16 responses so far, and 2 are saying rarely. The majority so far are assessing pain in athletes often, and some are doing it always. So we have some amount of experience in this audience, and I'm grateful for that. So what we want to look at is the fact that an effective assessment, pain interview sets the pace and expectations for the management process. Why? I'm going to be repeating the demographic of the young athlete. You have 10-year-olds, you have 20-year-olds. That spans quite a range, and there are different dynamics that come into play when we are assessing pain in these persons. And the pain interview, which is the starting point of them telling their pain story, is essential. And therefore, what we're saying is, if it is that we can have an effective assessment, which includes the interview, then that sets the pace. There you go with one of those puns again, for the expectations for management and also improved outcomes for management, because much of what we do is about improving outcome, right? We want to do something so that we can get a better management of pain, so that it can have an improved outcome and improve long-term care for the whole athlete, not just the athlete at a moment in time. And so keep that in mind. So what used to obtain is that there was a pain interview, which was very data gathering, very data driven. We had our pens in hand and we had our heads down and we were pretty much just checking boxes. Sometimes we wouldn't engage very much. If we looked up, we wouldn't be able to tell who was the different patient. Now, I'm speaking from a physician point of view, but I do also appreciate that the physicians are not the only ones that engage in the pain interview. But from a physician point of view, sometimes we were focused only on data gathering, as if that was an endpoint. And what we are moving towards is a therapeutic, patient-centered conversation now. And so we want to change how we communicate to make that communication more effective, so that we can understand the pain story, so that we can manage it better, and so that we can have better outcomes. Very simple. But in doing that, I also want to take note here that Sometimes when we are making progress, when we are changing, when we're coming to webinars, when we want to learn, we get the sense that what we are doing is wrong or has failed. No, I want to acknowledge the excellent work that is being done by you in managing pain in young athletes, because the feedback that I've gotten in just anecdotal speaking to some of the stakeholders is that they may give you a 6 or a 7 out of 10 in terms of managing pain in the young athlete. And remember, the span is wide. And so you can take some credit for what you're doing, but we certainly know that there is room for improvement. And that's what I want to focus on today. As you take credit for what you're doing, do what's good, and then let's focus on where we can fill the gaps, as it were. So the pain interview, talking to the young athlete, I mean, the pain interview is just a euphemism for talking to them. The purpose of it is to build rapport. We want to engage with them. Starting point, we want to make eye contact. Very important. Some of us are not as comfortable with making eye contact, but we need to establish a rapport. We need to make sure that the ambience and the setting is comfortable for not just the young athlete, but for you. Is it safe? Is it private? Because some things may come out of the interview that the young athlete may want to disclose and may not want to disclose to other persons. And so we want to be aware of our setting and how we ask certain questions. We want to be mindful of that as we are engaging, because we want to build this improved therapeutic alliance. We want to ensure that we are compassionate and we're empathetic. Now, different ones of us have different levels of compassion, but I believe we all have an underlying ability to empathize and to be compassionate. And so the young athlete who is in pain or who is having pain has a multiplicity of concerns, and compassion is a good place to start. It doesn't mean we're cuddling. It doesn't mean that we are ignoring other things, but it means we are accepting and understanding at a baseline that this is an unpleasant situation for you. And we are saying in our even body language, we are going to try to help. We want to ask open-ended questions. I think many of us are very familiar with the sometimes now overused videos and memes of the adult talking with the young person. Now remember, the young athlete, 10, 19, 10, 20. And talking with them sometimes can be a challenge. Many of us know that when we ask closed-ended questions, even outside of pain management, we will get a, how was school today? Fine. Did anything good happen? No. Are you hungry? No. Do you want anything? No. It's very closed off, and it doesn't allow for discussion. It doesn't allow for us to decipher anything. And so in our interview, as engagers and stakeholders, we want to ask open-ended questions, and we want to be giving opportunity for the answers. So again, many of us are very good at talking, but not so good at listening, right? And you have heard that we have one mouth, but two ears. So we should listen twice as much as we speak, in the context particularly of a young athlete, a young person who may not be as comfortable engaging with an adult. There are lots of dynamics. And so you want to set the tone where it is affording you a baseline that this is a safe space. I am here for you. I want to hear what you have to say, and what you have to say is important. And to pull, as it were, information out of them, not aggressively, but allow them to fill in the blanks, fill in the gaps. And I'm going to be repeating this from time to time. And we want to remember that in pain, it's such a multidimensional issue that you have to focus on the biopsychosocial approach. And I believe that Mr. Nicholas Powell has a particular bend on that. And I look forward to the presentation, as I said, where we are not just treating a number. We're not just concerned about what is your pain score, but we want to know what are the implications, the impact on the biology, your biology. Again, the biology in a young athlete varies. They are growing, there are growth plate issues, there are emotional issues. Psychologically, the development in terms of even male and female, young male athlete, young female athlete, puberty, body awareness, feeling overwhelmed, and social, how they engage with their environment in terms of this pain. When there is pain, how does it change my value as a person? Do I see myself, if I'm no longer a member of the track team because I am pulled for injury? Do I lose my value? And so pain is not just a number. Again, one of the things I want to drive home today is it's not just a number. There are so many other things around it and surrounding it that your interview and your interview skills can bring those out and can help to manage more appropriately. So as we continue with that, again, pain is subjective, multidimensional, as I have mentioned, and we are all familiar. Sometimes I try not to mention it, but it always comes up, that in the definition of pain, according to the International Association for the Study of Pain, which is our august governing body, it allows us to describe pain as an emotional, unpleasant, sensory event. It may or may not be associated with tissue damage, so you don't have to have a fracture, you don't have to have a sprain. You can have pain outside of that, which should be treated. Remember, pain is a signal, it's a sign. It says, in general terms, something is wrong, and you need to pay attention to it. So again, from our interview point, we want to respect the pain. We'll use things like that. We want to affirm the young athlete and ensure that they understand from us that we are here to help, that your pain is important and it's not in your head because I have not seen a fracture or your scan says there's nothing wrong. We want to avoid those negatives and ensure that we are allowing for that, again, therapeutic alliance to take place and the young athlete feels very supported. So why are we talking about this? So what? Pain, we do an interview. Why is this even a thing? Why am I starting the innings? Because poorly treated pain has a consequence. Poorly treated pain can be catastrophic. Poorly treated pain can cost. And in the young athlete, again, we're focused on this individual who is at varying levels in terms of their emotion, varying levels in terms of their physical development, varying levels in terms of their potential. If we do not, as stakeholders, treat pain properly, which means treat it effectively, promptly, and to the best of our ability, which includes referral, which I'll talk about. If we don't treat pain properly, it may lead to chronic pain. And I'll take a point here where acute pain in terms of terminology is, some of us will be aware that it's usually pain caused by inflammation, usually pain before 6 weeks, 3 months, some will say, and it usually goes away after whatever inciting issue has resolved. There's usually no functional residual effect. However, if we don't treat pain properly, we are at increased risk of chronic pain. And chronic pain is a different beast altogether. It is not treated with an anti-inflammatory, ice it and let's go. This is where you have neuronal changes, you have neurotransmitter changes, you have central sensitization, and you have pain that is difficult, even more so, to treat. And this chronic pain can have significant impact. In the US, some of the studies are suggesting that $60 million per year is spent on chronic pain management, from loss of income, persons not being able to go to work, persons being able to not contribute to GDP, supporting them because they have to go to doctor, etc. So it's a costly venture. So if we think of treating pain properly, we can reduce the incidence of chronic pain. We can also reduce this increased length of inactivity. If I don't treat pain properly in a young athlete, this young athlete who is waiting to go to Carifta, who is training for cricket, whatever the next cricket tournament is, who is an equestrian rider, who is in the pool, they may have increased length of inactivity because I am not adequately treating their pain. So they're staying out of competition, out of training longer, and that can lead to deconditioning. There can also be a loss of status or function. And as I had mentioned, if there are some elite athletes, for example, who are medal contenders, these are athletes at the highest level and they are ready to compete. If I do not treat the pain properly and they are not able to compete, or it affects their competition readiness or their performance, then certainly these athletes may have a problem in terms of their loss of function and status. If I'm in tennis and I'm seeded at number 1 or number 2, I may drop in rank, and that can have a big impact for the psychosocial, the cognitive impact on the young athlete. Now, again, the young person at baseline, higher risk of anxiety and depression. We spoke about some of the reasons. Puberty, self-awareness, being a part of a group, wanting to fit in, not sure who you are. Many things can happen. And at baseline, you can have anxiety and depression. So consider the increased incidence in a patient who is a young athlete who has pain and is already at a loss in terms of being out of function or injured and has concerns about it. So anxiety, you want to be looking out in your interview for any issues with respect to anxiety and depression. And we do know some of the symptoms of depression where you want to be talking to them about sleep, Are there any sleep disturbances? Do you feel any sense of guilt? Are you losing interest or have lost interest in some things? What's your appetite like? What is your agitation, psychomotor changes? And a big one you want to ask, and we have to be prepared to ask some tough questions. And that is one of the reasons why we want to have a space that is safe, that allows for privacy, and that allows for full expression. You want to ask a young athlete who you think or suspect having depression, do you have thoughts of self-harm or thoughts of harming other people? Because suicide is a risk of depression, major depression. And there can be situations where, because of pain, because of injury, because of negative feedback, because of loss of your position and all other things, there may be this young athlete who is showing signs of suicide or suicidal ideation, and that needs an immediate referral. We want to look at the costs in terms of money, dollars and cents. It all boils down to dollars and cents for some. Again, if I am a 10-year-old or 12-year-old in Cornell Day Primary, and I have been an athlete, a runner, a jumper, track and field, doing well, I've gotten a scholarship to a high school and they're going to pay my way for 5 years. If it is that I have this injury, for example, and I have pain and it's poorly treated, my tuition, my scholarship may be at risk if I do not compete, if I do not play, if I do not suit up, if I do not strap up, then there can be a problem. And so we want to see that treating pain poorly, inadequately, is and potentially very damaging to the young athlete and to their environment on a whole. And so I hope you understand the why. And there are so many other reasons, but these are just some. So when we are doing our pain interview, we want them to tell us their pain story. We start by taking a focused pain history. And the focused pain history is trying to get information, trying to get them to talk, trying to get them to explain beyond just the words, trying to understand the pain, the cause, as well as any complications and any risk factors that the young athlete may have. And so the focused pain history allows for you to talk about things like, and we have a mnemonic, and there are many mnemonics. For those who like it, you can talk about Socrates, Socrates, and that is S for sight. Where is the pain? Where does it hurt? The onset, when did it happen? The character of the pain, is it burning, pressing, sticking, aching, numbing, throbbing, etc.? Any radiation or movement, does the pain move from one place and go to another? For example, I have back pain, but it also affects my knee. And we know that in a lot of the young athletes, one of the areas that is most highly impacted in terms of incidence of pain are the knees. And so knee pain is quite common. 80% of the young athletes from time to time who have pain may indicate that there is knee pain. So you want to talk about radiation, timing. When does it come on? Does it come on more in the morning or in the evening? Does it come on more when I am doing other things? So any exacerbating factors, what makes it worse? Any relieving factors, what makes it better? You want to talk about the pain score. You want to establish that a pain score is a good way to tell me the severity. How severe is my pain? How hot is my pain? But it is not the only way. And we are very accustomed to the numeric rating scale, and it's well validated, quite useful. But again, remember that within the gamut of this young athlete, within the age, cognitive development, even the intellectual ability and capacity of the young athlete, not all may have achieved mastery to be able to know that a pain score of 4 out of 10 is less than a pain score of 8 out of 10. And so we don't want to be fixated on give me a number, give me a number. We want to be able to speak differently so we understand and they feel as if they have been heard. And so we're going to talk about some other tools that you can use in the focused pain history. And then conducting a physical examination. And this is not the scope of my presentation, but I'm going to make a note here. Every one of us who engages, those of you who contributed to the poll and spoke about how often you are engaging in the assessment, you should conduct a physical examination. And the extent to which you conduct that examination will depend on your skill and your capacity and your training. So I expect a physiotherapist will conduct a physical examination in a different way than a physician and than a coach and than even a teacher. So with this conducting of a physical examination, I'm going to say here that we need to be mindful of the young athlete. We want to ask permission. Can I touch you? We want to also get a surrogate, an adult appropriate surrogate within the space that we're examining for our safety and for the safety of the young athlete. Remember that not because we are a coach or a doctor, it gives me permission to touch. And some young athletes, again, remember we're going through that awkward phase. Some of them, I don't know this person. Until they're comfortable, they may not feel that they are in a position to allow you to touch. And so we want to be respectful of that. We want to move from the very dominant, domineering, I'm the doctor, I'm the physio, I'm going to tell you what, and we want to be respectful and build alliance. And you also want in the physical examination, of course, to be mindful of the gender roles. You want to be careful, males examining females in what capacity and to what extent. And you may, again, want to defer a physical examination if you think that this is not the best place, time, and it may also be the emotion of the young athletes. I want us to be mindful of that as well. So here's another opportunity for you to jump right in with me. So these are some examples of assessment tools, and there are many, but self-reporting, movement testing, pain scale rating, and functional performance. What do you think is the most useful? And can you rank them for me here from the ones that I've given? I have not given an exhaustive list, but these here tend to be more common. So engage with me. What do you think is rank them in terms of their usefulness, in terms of assessing pain? For those who obviously assess. Those who don't, if you want to give a go at the what you surmised, I would love to hear that as well, or I'd love to see that, and we'll discuss what the results are. So the question is, rank the most useful pain assessment methods here. Thank you so much. So again, I'm interested in the results so far. I love that there is functional performance scoring high, most useful. Pain scale rating, again, tried and true. And as I said, I don't want to come here and what you hear from me is don't use the numeric rating scale, or what you hear from me is what you've been doing is bad. No. We want to work on what we've been doing well and open up and expand and fill in those gaps. And so we really want to not throw the baby out with the bathwater. So I'm going to take those responses so far, and I know it's dynamic. But so far, I'm getting high ratings in terms of movement testing, pain scale rating. And this is excellent as well, because remember, we're dealing with athletes. And the expectation, the outcome, the goals are going to be different for a young athlete than for a non-athlete. What do you expect? What are your goals out of this assessment and out of our working together? I know physiotherapy is excellent at setting goals. They'll send back those sheets to me, and it will say what are the patient goals, and to the extent that the goals were achieved. I would add that the goals are not just physical, and that's more so, I suppose, for the sports psychologist, for the sports physician, for the pain management physician, where we're also thinking, as I said, of the biopsychosocial, the cognitive, the emotional as well. So we're getting high ratings for the pain scale, movement testing, functional, and the athlete self-reporting going at 4, which is interesting. So you're thinking the most useful, athlete self-reporting, not so much. Okay, let's see what might be coming out of some of the research. All right. So I looked at this particular study. It's a qualitative study, and I thought it gave an interesting perspective and an interesting way to evaluate and analyze. And remember, we're talking about the pain interview. We're talking about how can we know the story? How can we decipher the hurt? How can we understand and enhance, through enhanced communication, how our outcomes can be improved? So this is a study by Purcell et al. Coming out of Ireland, and it's published there. You'll see the information. And in it was exploring athlete pain assessment experiences and their priorities. It was in 2 parts. Qualitative, as I said, looking at the hermeneutics, which is not just about the delivery of data, but interpreting it in the face of their lived experience. These athletes, these physiotherapists, how are they experiencing pain from both sides? Because some athletes had some physiotherapy experience as well. And what do they think are the priorities for pain assessment and beyond? And so using this a lot, I will reference going forward. They came up with pain assessment in 2 groups, and they suggested and recommended that there be subjective assessment and objective assessment. And this is not new to us. But again, focusing on the point of view of these focus groups, they thought that they ranked the numeric rating scale, visual analog scale as important. Now, we spoke about the NRS, and we know 0 to 10 visual analog, again, shows pictures and their faces scale, many assessments that we can use. And again, based on the age of the patient and based on their cognitive, developmental, intellectual level, we can show them that. The traffic light system is an interesting system as well, where it allows more care to be given to the patient. We want to empower the young athlete to manage their pain as well. And what the traffic light system does is it codes yellow, green, red. Green, according to a pain score. Green, if you have 0 to 3 pain, and it tells you, can you engage in movement? Can you engage in activity? Can I go to training? Can I do this drill? And what the traffic light system is, if you have 0 to 3 pain, you are going to say, it's go. I can go ahead, I can do what I normally do in addition to your pain management. If the young athlete has pain that is 4 to 6, then the young athlete that is yellow, amber, caution, and you want to stop. You don't want to do any activity there, and you want to engage with your therapist. As well, if you have red, if my pain is exceeding 6 out of 10, no, you're not going to go to training that day. No, you're not going to do the drill. And it allows them to feel empowered. It also allows sort of a progress. So I was at red, and then I'm going to now be at yellow and green. So these assessment objectives are very helpful. We also know the brief pain inventory and the McGill questionnaire, and in the interest of time, I'm going to allow you to look at that, and I'll be available for questions at the appropriate time. The ecological momentary assessment, these are subjective assessments that we are using daily now. Technology is everywhere. And so the use of digital diaries, the use of these armbands and apps, there's an app for that, where patients are able to engage, log their pain, and this is ecological. So it's where they are in their habitat at different times, which is excellent. It expands that communication. It closes those gaps. Because when we were doing sort of traditional pain assessment, pain history, it was when I saw the patient at a single point in time. But now I'm able to have the patient tell me what is happening. Now, we used to do pain diaries and we wrote those down. But again, these are more they are delivered on time, and they can be synchronized to the coach, to the physiotherapist, and to the caregiver. Contextual interview, pretty much what I was talking about, and the body diagram map, very useful because it adds and opens up the scope for the giving information that the athlete will provide for us. So the athlete can put on a body map where the pain is on their body, and that's very useful. And then objective assessments, this study also spoke to and supported sport-specific functional assessments. So drills, sprints, jumps, depending on what it is that you do. Quantitative sensory testing, plates that you're going to stand on that will check your pressure, the amount of weight you do, balance, any even muscle length. These are helpful as well in your assessment of the patient, the young athlete with pain. Physiologic markers and technology and skin conductance, heart rate testing, a big push and a big thrust for incorporating more technology into how we are assessing the young athlete. And this is a picture of the brief pain inventory, which we are very well aware of. And I also have a short form McGill questionnaire. And I put here the short form. Why? Because again, cognitively, most of the young people are distracted. Am I right? We want to swipe. We're not interested in filling out a form that is 78 points. We don't want to sit down and process things like that. So you want to maximize the time, though you are not going to rush, but you want to make sure that you are using the time as effectively so that you can continue to have engagement. You don't want to have those lulls where you've left the interview and there is no information or little information that you've gotten about the pain. And so the summary of this study, this qualitative study out of looking at focus groups of of physiotherapists and young athletes, they had what you call themes and themes that they promoted. And so they spoke about enhancing communication and improving pain descriptors. So move beyond a numeric rating scale to something else. Talk about how the pain makes you feel, how it's affecting your function. Were you able to do your training yesterday? Were you able to do your jumps? Give more of a description on the pain other than and apart from a numeric rating scale. And it spoke to using sport-specific multidimensional assessment and including technology. So let's check out the apps. Let's see if we can use those digital diaries. And there is going to be a point where we have to speak to data protection. How do we incorporate that information that we get from those ecological assessments to incorporate it into our traditional patient file? And how do I manage that data legally? What are the implications for me if there are hackers? And so we still have a few kinks to work out, but it is an exciting, interesting potential in terms of enhancing communication. So may I have some feedback again now? What would what would improve pain conversations the most, you think, based on what we've been saying, and even your own ideas and opinions? If I didn't share something, what do you think could improve pain conversations the most? What are some of the things that you think can do that? And these are open-ended for you, so you can write whatever comment you like, and we'll be able to see that and share that amongst ourselves as we look and continue to look at the pain interview, enhancing communication in the young athlete to improve outcomes. So what would improve pain conversations most? What do you think we could add? What do you think we need to do in order to do that? And I'll give a minute, less than a minute, for the participants to respond as you so desire. We want to know, what else could we do? What are we missing? How could we improve those conversations that we're having with those young people, with the young athletes, as they are about pain and as we talk to them about pain? And remember, it's not just the coaches that are doing it. Parents, as you have a child that's a young athlete, a gymnast, and many of the young athletes might be involved in multiple athletic programs. And so you want to be having those conversations about pain and being a safe space for the young athlete to be able to bring any issues that they have to you. And you may not necessarily see a limp, but pain might be present even before that and without an injury. All right, thank you so much for those responses so far. So what would improve pain conversations most? And some of the feedback: be more relatable, absolutely, and use those objective tools. Great. Remember, I don't want us to not use the subjective, but we definitely incorporate more objective. Group therapy, open discussions, that's awesome. I really think that would be helpful. And young people tend to open up with young people, so age appropriately, that might be something useful. And it helps you not to feel so alone, because I'm not the only one injured or having pain or have had a history of injury. Videos of persons with similar presentations, that's right. We definitely like to see others in our position, in terms of it helps us to not feel so alone. Building a relationship with the patient, factoring psychosocial impact, yes. Video again, playing in strongly, allowing the athlete to inflict a similar pain. Oh, I don't know. Interesting perspective. Interesting. I don't know. I used to do a lecture and I gave them tied a glove on their hand with a volunteer to simulate pain and to simulate sort of what happens as we become more adapted to pain. And I've stopped doing that though for now. Being less dismissive and taking a look at the whole picture, absolutely. And asking the patient what they think we can do to help. Yes, how can I help you? How do you think? What can we do? Again, that collaborative approach, that is absolutely helpful. And numerous studies have just told us how important that is to improving outcome. And so when to refer to a specialist. So this is going to be, I'm coming down. This is going to be my closing in terms of the final idea, because as a pain physician, one of the challenges I have is that I sometimes will see patients, not athletes necessarily, who have had pain for 5 years, 2 years, 7 months, 10 months, and they come to me now and I think, what am I going to do with you? And what am I going to do for you? Because the pain is so far advanced and I am just now getting the opportunity. And you also have to deal with the emotional aspect of, okay, this is 10 months in, this is 2 years in, this is 3 years in. So I'm asking us to consider referral to a specialist, consider referral and consider referral early. So when do we refer? I want you to consider referral immediately. Red flags in red for a reason. Visible deformity of the young athlete, immediately. Inability to weight bear, immediately. Rapid swelling, immediately. Numbness, tingling, loss of sensation, I can't feel, immediately. I like to say, do not pass go, do not collect $200. Concussions, signs, confusion, vomiting, memory loss. Now remember, your young athlete may have pain because of an injury, which might have been associated with trauma. Now, if there is a tackle, and I'm going to pick on my limited sports knowledge. If there's a tackle, there can be a significant blow. Again, in one of those discussions with Don Anderson. There are, for example, there's an ice hockey team in Jamaica, and just hitting the side, hitting the walls, it's a tough sport. It's a physically demanding sport, and there can be concussions, and we want to look for that immediately transfer. Prompt or delayed transfer at your discretion within a particular time, days to week. Persistent pain, if you're having pain for more than 3 to 5 days, you've done the usual, rest it, ice it, give it the NSAIDs, still nothing. If the pain is chronic, please refer. Reduce range of motion. I'm a thrower, baseball, badminton, tennis, and I'm not able to move my upper limb as well. And I look forward to Alison Taylor talking to us a little bit about hand and how that is important for us. Pain disrupting your sleep. So yes, I'm having pain, but I really am having a major challenge with my sleep. That sets us up for anxiety and depression and a whole other issue. Let's transfer. Recurrent injury and pain that occurs or returns during training, we really want to refer to a specialist, and be advised where you refer. You know, there are many persons, not many pain physicians, but there are many physiotherapists, some that are very specialized in terms of pain management and specialized in terms of sports medicine. Let's refer. It's best that we refer and we hear, I am not the best, or this is not appropriate, or there is nothing to worry about. But again, the impact on the young athlete can be catastrophic if we fail to do our job, including an excellent pain interview. And so in closing, the pain interview is a key first step. First up to bat, first innings, it's key. And if we get it right, and getting it right includes effective communication, utilizing that biopsychosocial approach, and also emphasizing education, because one of the things you want that young athlete to leave with is being empowered in terms of what is causing my pain, even if I don't know directly. You also want that young athlete to feel empowered about his or her body and about how to even reduce the risk of further injury if there was an injury, and as well what to do in terms of even things like the traffic light. How do they participate in their own pain management so that they can understand and also reduce the outcome, the negative outcomes of pain in the young athlete. So I just want to say thank you again to the presenters and to the organization, and I look forward to the presenters that are coming, and I will take any questions at the appropriate time. Thank you so much. Enjoy the rest of the evening.
Thank you, Dr. Chang. I thoroughly enjoyed that presentation. So in the interest of time, what we'll ask is that if persons have any questions, please put them in the chat, and then you can go ahead and answer them in the chat, if you don't mind. Thank you kindly. All righty, let me just give a second or two for any feedback. All right, have some feedback coming in the chat. All right, so we'll just jump on into our next presentation, and we'll have Mrs. Brown introduce our next speaker, and this will be on the topic of treating without pain in sports, and this will be done by Alison Taylor. So go ahead.
Good evening, everyone. A great pleasure to introduce my friend and colleague, Alison Taylor. She's a fellow CKTI, kinesiotaping instructor. Alison is an occupational therapist and a certified hand therapist. She hails from Australia and now resides in Dallas, Texas, USA. She grew up in a wonderful beach town in Australia called Wollongong. I hope I got it right. And moved to the USA after graduating with her OT degree from Sydney University in 1990. So she has been practicing roughly over 35 years and teaches nationally and internationally on taping, tendinitis, pain, and sports rehab. She's an NTD certified practitioner, and she's a certified kinesiotaping instructor since 2011. She's the originator of the Treating Without Pain methodology, an innovative patient-specific approach which integrates sensory, motor, and neuroplastic principles to restore function without provoking pain. She's an internationally recognized educator and has spoken in over 5 international hand conferences and 7 ASH conferences. She was a keynote speaker for the Asia Pacific Hand Therapy Conference in 2023. Alison has published in several hand journals and contributed to books and magazines about the hand. Her work extends into elite sports performance. At the Baylor Scott and White Sports Therapy and Research Center at the STAR in Dallas, Texas. This is the largest nonprofit healthcare system in Texas. And there she's a star amongst the Dallas Cowboys who she treats. Alison serves as a consultant in rehabilitation and injury management for high-level athletes, collaborating with individuals and organizations connected to the NFL, the MLB, the NBA, and the NHL. Her work emphasizes neurosystem-driven recovery, bridging high-performance sports and rehabilitation to achieve meaningful outcomes without pain. Please help me welcome Alison Taylor as she shares her treating without pain concepts to help us decipher the hurt and treat athletes' pain.
Oh my goodness, thank you, my friend. Can everybody hear me? I don't see any hands, so if somebody can just put a hand in the chat. Okay, great, thank you. Perfect. I should have recorded that, Pierre-Anne, because that sounded like I was amazing. So I really appreciate that. So I work, I'm going to share my screen. Everybody has they have the PowerPoint, but I'm going to pull it up right here. And let's get rid of the chat. So thank you again for having me. I, again, trained in Australia. I've been in sports, starting off originally with the Major League Baseball Braves. My boss in Atlanta was the head orthopedic for the Braves. So I've been in baseball, but my favorite things are overhead athletes because I was a tennis player. And I've had the privilege to teach at the National Tennis Centre in London, primarily to tennis professional PTs and athletic trainers. But the clinic I work in Dallas is part of the Dallas Cowboys organization. We do treat the cheerleaders. We have combines for the NFL. We have NBA. We have we consult with again with baseball and football pros, but we do have a lot of younger athletes. And I really loved Dr. Pollyanna's last lecture, integrating the importance of discussing and having the right tools for not just the professional athletes, but the younger athletes. So this was really an amazing lecture. And I love when we all speak about the same thing. So anyway, I'm going to try and go through this for the people that don't know me. I've spent over 10 years, again, with Pierre-Anne. I am a kinesiotaping instructor. So a lot of the foundation of what I do is based on taping, but I utilize a lot of other treatment models and approaches. But my foundation is based on the fact that I started video recording my patients in 2016. So because of that, I've established I would say, the largest treatment database in the world, with over 16,000 videos that just sit on my phone. And I'm trying to get them out to everybody in a way that is seamless and helpful for everybody. But because of my videos, I've discovered a lot of things that we were told in the way of pain or the way that we've been treating. Again, like Pollyanna said, we're not doing anything wrong, but we could do other things to enhance what we're doing. So for me, I focus on the superficial layers, which is more the skin and fascial layer, primarily the skin layer for me, which means everything we've been doing to this point has been amazing. We get better outcomes, people get better. But if we sprinkle the top of that cake with a little bit more skin, we would do even better. So the important point of this particular slide is, let me just minimize this so I can see, is that the skin layer is where the highest number of sensory receptors are. And that includes the pain receptors, which are the nociceptors. So if you look at this image, those pain receptors look like little trees, and they're up at the very top layer, right close to the epidermis. And they're also up there with a couple of other sensory receptors, which are very important. The first is the Merkel discs and the second is the Meissner corpuscles. So you can see they're very much right at the top of that skin layer up there with those nociceptors. Now, what that means is that when you look at this dermal layer receptors, all of those receptors are telling the brain what's going on in an area, not just from the outside, but they're also going to give information on what's happening below the surface. So if we focus on the fact that the skin has the highest number of pain receptors, then we could really control or almost possibly manipulate pain in our patients. And it really means when we look at our patients, we should be looking at what happens at the skin layer, not just from an impact area. Say somebody gets hit in the leg with a hockey stick, or somebody gets hit in the finger with a cricket ball, or if somebody, this is fun for me because in Jamaica you talk about cricket and I'm Australian, so I'm just adding that in. So here, if somebody gets hit while they're being tackled, so in the body, everybody goes to the area of injury. But there was a little mention, again, from Dr. Chang about concussions. And that's a really important point because in concussions, nobody goes to the area that you had the concussion. Nobody treats the head. But in an injury in the leg or the extremity, therapists will go to the extremity, massage, do tools, do tuning forks, I do tuning forks, do TENS, we'll do modalities. But when it comes to a concussion, nobody goes to the head. And I think that's a really important point. But anyway, back to the skin and the sensory receptors. So if you look at the sensory receptors, they go in an order according to depth and frequency. So the top layer, the Merkels and the Meissners, function at a frequency of about 5 to 30 hertz. Hair follicles are also light touch receptors. So there are 3 light touch receptors. Oh, sorry about that. Oh, I must be on a timing that I wasn't aware of. And then you go down to the green areas, which were Ruffini's, which are skin stretch receptors, and then down to the Pacinians, which are deep pressure receptors. So the important part of my lecture is my focus when I treat, whether with my hands, tape, tuning forks, cups, whatever, is to stimulate the right receptors in that dermal layer to get the athlete back quicker by eliminating swelling or tightness or stiffness or pain. So the more we touch the outer layer of the skin, the faster we can get people better. So the Meissner corpuscles that you see there are light touch, light vibration, and the Pacinian corpuscles are deep pressure, deep vibration. And both of those receptors are fastest to the brain. So the important part for me when I'm treating is looking at pain from a gate control theory. So pain and temperature, and that's extremes of temperature, they're very high or very low, are on the spinothalamic tract, and they get to the pain by signals to the brain, and the brain processes that information. Now, all the other sensory receptors are on another pathway. The vibration, the pressure, the light touch, proprioception, non-painful receptors are on a different pathway. So essentially, if you can stimulate a different pathway, which we're already doing by our touch, our pressure, our cups, or any of our treatment modalities, heat or cold, we're already stimulating these other receptors. But can we be very deliberate in our approach by stimulating the right receptors? Now, again, the light touch, light vibration, or deep pressure, deep vibration receptors are faster to the brain. So essentially, if you stimulate that, it will cross over, it will shut down the pain gate, essentially stop the signal to the brain by stimulation of those other receptors. So Meissners and Pacinians are our favorite ones to stimulate, but Ruffini's are something that is a slow receptor, slow adapting receptor that we can stimulate with tape, and that then it can keep the stimulus for a long period of time. So therefore our athletes can compete even by just using tape. So people don't often understand taping, but when you break it down, looking at its influence on the sensory system, it's quite easy. So the first image to the left is not my image. It came from a friend of mine who took my class in Hawaii. Now, the top image on the left of the hand and the bottom image are only 1 day apart. So essentially, when you look at the sensory nervous system in the hand, you have 2 very sensory effective or fast communicators to the brain. The thumb is the most perceived in the brain after the face, the lips, and the tongue. So that means your focus should be on the thumb. And the sensory receptors in the hand of the thumb, index, middle, and ring are primarily innervated by the sensory branch of the radial nerve, and it covers that whole area. So by placing a piece of tape with a light tension over the sensory nerves in the hand, not just the sensory branch of the radial nerve, but the dorsal cutaneous branch of the ulnar nerve, you're changing the influence of the information to the brain. So the brain is now receiving information from the tape, which is a light touch influence, which gets to the brain faster. So essentially, if we are clever enough to manipulate the information to the brain, we can do that effectively by focusing on this dermal layer receptors. Now, if you look at the other one, this was a professional basketball player that I saw. You can see the above picture. This is a taping application that we have. And then you can see the change in. Oh, I'm sorry. Can you guys hear me? All right. There's something in the background. Okay, I'm not sure where that noise is coming from, but anyway, but you can see the difference in the above and below picture, in the width of the foot, the swelling in the foot. You can even see the color difference between the top part of the foot and the bottom part of the foot just by applying tape over the joint. Now, the Pacinian and the Ruffini receptors are very heavily embedded in joints. So they're not just in the skin layer, but they're also in the joint layer. So if you're working with athletes that you have, like a soccer athlete or a lower extremity athlete that has to move quickly, maybe a tennis player, you want to stimulate the receptors in the ankle joints and do that effectively with something like taping or cupping or something that gets that skin and that tissue moving, but also stimulates those deeper physiological layers. So we can utilize that with our hands, with tape, or with whatever. So fan taping is a great way, again, from the kinesio taping stuff that we do. But from a psychosocial perspective, which Dr. Chang just spoke about, the quicker you can get rid of bruising and swelling, the faster the patient feels like they're improving. So if we can do that by creating pressure gradients and channels where you can move the fluid out of the area quickly, and from the visual motor perspective, the patient does no longer see an injury, then that psychosocially is really important, especially again in these young athletes. You might find that they have one injury and then that leads to another one and another one and another one. And that's when we talk more about fascia. So this is just a really good image of a patellar injury that within less than 7 days, the swelling was reduced and the bruising was gone. So again, so obviously this gentleman is not an athlete, but I wanted to show you the power of taping and the fact that when you provide a stimulus to a muscle, and it doesn't, again, have to be just tape. It could be some kind of electrical stimulus, your hands or a cup. When you provide something through the skin layer over an area that you want to stimulate, you can effectively improve motion and decrease pain. So here's just a video of this gentleman. Now, just for reference, the lady in the background is my friend Shruti. She is a PT who had never done this. So this is the first time she did it. I kind of guided her what we would do in therapy. The gentleman has a lot of pain, so we would use a very light cut taping, but it's placed specifically over the muscles, and the brain focuses on the muscles after that. Okay, how's that feel?
It's stuck. It hurts.
Painful? How much pain? 0 to 10?
Hey, that's about an 8.
All right, you can relax. Okay, ready? Now, the important part of this video is that the man puffs and blows, which means his
Oh, it's about a 3.
superficial layer is adherent. And now when Shruti changes her hand direction,
No, that's.
Oh, never mind. I think I can't do it all.
he actually can't move. So now as she puts tape over the same area that she placed her hands, where he gained at least, double the motion, and now she tapes for a muscle. This is more of a supraspinatus taping.
35.
Mhm. You'll see here that the man's total range of motion is restored just by giving
Yeah, better.
a feedback through the skin to the brain, through the sensory nervous system.
Yeah.
And now he has double the range of motion.
And then, is there any pain left?
A little bit.
Mild?
1.
Okay.
And what's really interesting is when you actually take pain away, what Dr. Kase would say is that the brain is hierarchical and it's going to focus on what is the most prominent information that is going to it. Now, when you change the information and you change the outcome, it's now not focused on that location. So even just providing some kind of stimulus through the skin on a location that you suspect is impaired, you can change the information that the brain A receives and B, how it responds. So that's what we're trying to do, whether we do taping or any other modality. So this is just a joint taping or a joint application, just to show that, you know, we've got skin and we've got fascia and we've got muscle and joint. So this is a patient who's actually an Olympic potential gymnast. Well, he was in the Junior Olympics squad. He was training, you know, 6 hours a day. He was homeschooled, but he had a a middle finger fracture on the volar plate. And this was my first visit with him and the second visit with him. So go ahead and make a fist for me, best you got. Lift your hand like this. This is about 5 out of 10 pain, right? Yeah. Tape. Okay. Go ahead and make a fist again. Any pain?
No.
Come on, like this. Not to give me a high five yet, but you can in a minute. Okay, make a fist again. Any pain?
No.
Say that again.
No.
Straight it all the way back up. Beautiful. Go down again. Nice.
I'm doing my shoot don't talk. I don't know why I tried.
No pain, right?
No.
Same time, because we've been in a corporate plant, I needed a little bit of.
Good. Do it again. Run it through a couple of times. Nice. No pain.
No.
No pain. And it's 1 day later.
Yeah.
Okay. Do it again. Beautiful.
I'll work on you next, Stephen.
Got it. So what we don't normally see is an outcome that is that quick. So in 1 day, we have a very poor alignment, and then the next day we have great alignment, which is really important for our athletes. We actually live in an area in Dallas that is very heavily located with people from India who love playing cricket. So I get a lot of ring finger, especially fractures. And, you know, these guys want to get back so fast to play cricket. But the way you approach the treatment right from the beginning is really important. So if you get the skin moving and the fascia moving, get everything moving quickly, my approach is pain-free, and I don't put anyone in pain, and I don't use splints. I use a lot of taping. I use a lot of tools to just keep everything moving. So you can see very quickly and easily, just by getting the alignment of the finger right, working on the right mechanics and isometrics initially, and then regular motion, then 1 day you've restored the motion of this small middle finger fracture. So it's a bit exciting if we integrate the sensory motor system or the sensory system that tells the brain what goes on, and then the motor system will respond accordingly. So that's kind of how it applies to the joint. So I have lots of different approaches, but I call thinking in opposition, and I can play this because there's no volume. But if you think in opposition, when you have a patient that has an injury or reports pain on a certain side, look at the opposite side. Oftentimes it could be, if there's no injury, it can be from a joint imbalance where the agonistic side is more dominant, the antagonistic side is underfunctioning, and the agonist side is pulling the joint offline. So we're looking mostly at the pain sites, but we should look at the other. Now, this particular person actually had a distal radius fracture, and he was probably, I can't tell you how many weeks he's in here, but he was about 5 surgeries in because the first surgeons did not do the right surgery. But all the scar is on the volar side of the arm, and you could see from the beginning it was very red. And if you use thermal imaging, you can track which sensory nerves are involved. So initially when he came up on the screen, I'll play him again, you can see the radial nerve is very heightened. Now, what I found is the radial nerve is the biggest reporter of pain in athletes, in any athlete. If people report pain on the volar side, it's generally because they have some kind of scar or more of a nerve compression. So if you're looking at your carpal tunnels, your cubital tunnels, your Gillian's canals, there are going to be more compressions on the volar side. You're going to have more pain on the dorsal side. So with the scar being on the volar side, right where that area is red, if you spend the time taking the skin and the fascia and everything and getting all the tissue to the opposite side, you will diminish the pain. And you can see by this thermal imaging that we actually successfully reduced the tension through that radial nerve side. So for any of your overhead athletes, especially ones that do racket sports, If they're giving you pain on the dorsal side of the arm, that would be consistent with the radial nerve. The radial nerve is the highest reporter of pain for me. The second biggest reporter for pain is the lateral antebrachial cutaneous nerve. Both of these nerves exit at the bicep. So the more somebody is immobilized or walks around in a position like this, the higher chance you have of those nerves becoming adherent at the exit point. And so looking at the nerve pathways, so rather than doing generic exercise programs, if we focus on the exit points of the sensory nerves related to where the description was given to us from the patient, or the impact points, or factored in where the scars were. So scars will pull on the skin and create tension on the opposite side. So you always want to look at where a scar is placed, what sensory nerve pathway it's on, and what is it doing to the opposite side. So here's just another thermal imaging one. I can play this again because there's no volume, but this will clearly show you this lady was a CMC joint surgery. But the pink pathway is what you're tracking right now on the image to the left. And you can see the whole radial nerve pathway lights up, but when she scrunches in on her bicep, this increases the tension through that radial nerve pathway all the way to the dorsal hand. So if you have somebody that has an elbow injury, especially this particular person had a distal surgery, but it lights up red where the sensory nerves are inflamed, and that will completely match the pain pattern that the patient gives you. So you can see there's little blue strips on her hand that makes it look cooler. They're actually kinesio taping strips, because we use this treatment approach called roadblocks that I came up with, that intersects the sensory nerve pathways that the patient would be reporting. Now, what's interesting, this lady will show you the back of the shoulder. So a lot of the patients have pain in the posterior shoulder. That will be the axillary nerve. And if you look at the left picture, that is the blue part on the posterior side. The axillary nerve is also the radial nerve. So you have a continuous pathway of the pink pathway up the arm to the posterior shoulder. And she points to it right there where it's the edge of where it's going. So we've got this long piece. And I'll just take the volume off that. And hopefully you can still hear me. And this shows where we taped according to these exit points of the sensory nerves, all the way down the arm. Front to back, it's all on radial nerve, obviously, not so much on the back side. We didn't need it because they're cool. Right. So we can utilize things like thermal imaging to help our athletes determine. And I use a brand. People might ask. I use a brand. It's big in the US, I guess, for hunters. There's quality of this thermal imaging camera. It's called an InfiRay. I don't have any financial disclosures with them. I do nothing. I just love that camera. But it's a great way to treat your athlete, because a lot of our athletes, and I'll give you an example, especially golfers, they will have maybe a TFCC injury. They'll have MRIs. They'll have all these things that will guide the doctors, but none of them come back with any information. And they end up doing exploratory surgeries because they can't find anything wrong internally with their testing. But what you fail, well, not you, but people fail to recognize is the importance of the sensory nerves over these locations. So if you have a ulnar-sided wrist injury from, say, hitting the ground or something hitting you, you should be factoring in the fact that the dorsal cutaneous branch of the ulnar nerve sits over the top of that area and also goes down. So if you're always hitting your cricket bat or your baseball bat, or also doing your golf swing, if you have some kind of adherence on those sensory nerves, it will not show up with testing, and people will have extreme pain. But the only way to really see it is usually with a thermal imaging camera. And I'm not usually looking at the temperature. I'm just looking at the irritability of the nerve fibers and how red it comes up. So anyway, another concept that I teach on, I hope I'm okay with time, feel free to interrupt me if not, is biosyntegrity. So I use a lot of things with anatomy trains, which I think treating athletes is really vital. And if you don't know this book, it's by Thomas Myers. It's very complicated, but the pictures are great. But you can look at these fascial lines as being connection points. So if you layer the skin over the fascia, the highest number of pain receptors are in the skin. If the skin becomes adherent to the fascia because of an injury, especially maybe a distal injury like an ankle injury, you could predict that your athlete could have a shoulder injury maybe 18 months later, or the potential to have an injury to that site because of these fascial connections. So this is a patient who, she's just a recreational athlete, but you can see how her old lateral ankle injury affects her shoulder. I was treating her for her shoulder.
Trying to work that one. Say it again. Oh, so she had ankle surgery. So we're linking this side of the leg up to the armpit. So do it again first, love. So you push through it, but not great. Yeah. And it's clicking. But if we go down here on the ankle and we glide all that tissue up, much better. Incredible. And no click, right?
No click.
Nice. How about that? That's pretty good.
Crazy.
Okay, good. All right.
Okay.
Yeah, you'll look
All the way back.
get in with your wrist.
Yeah.
Yeah, that's nice.
Yep.
We did the leg.
Much better.
Okay, at least we've got.
So the important part is to go to other areas. Now, the biggest areas that I've discovered that are problematic are the knee and the elbow, because that's where the neural system has to go over the biggest corners. Now, what we have to remember is pain is only reported to the brain by the neural system. But in therapy, we focus on the muscular system, the joint system, and all these other deeper physiological layers. But the skin, the fascia, and the circulatory lymphatic systems are continuous throughout the body. So if we look at pain as a multi-system thing, and even if you're looking at your patients, if you're doing range of motion on a shoulder or an elbow and they start moving their legs, you need to start looking at a biointegral model that there could be a connection from the upper and lower body. So again, a unrelated ankle injury is not unrelated over a period of time, maybe to a shoulder injury that just came. So on our athletes, especially if they have ankle, shoulder injuries, something, you want to track their scars or their injuries and start to determine where this could come from. So this is actually a kid that was playing football, went to there's a cat, collect the ball and climbed a fence and fell off the fence. So he actually had a lateral ankle injury on the right and a right elbow injury. And you can see when he tensions these fascial lines, how he cannot move.
And so that's nice. That looks good. Make that grip tight again. That looks good. All right, so then with, and try and put that leg back again and see. I don't think you can lift it up at all. Where do you feel that?
So if you watch this young kid move, his body's trying to get him out of that position. It's trying to unwind him and spiral him away. And when he puts his foot forward, he has no proprioception because his whole neural system was tensioned. He could not bend his elbow when his ankle was back, but he can bend his elbow when his ankle is forward. And all of this is really useful information if we're treating athletes, especially people who are pitching or throwing or bowling, doing something where their leg is away from their body, especially the opposite leg. This is a professional MMA fighter who had his signature move was a left hook, and he could not get any stability in his left wrist. We tried multiple things, but then he tells us that he had an old knee surgery on the left side.
All right, say that.
So when I'm sitting down, I do this motion. I don't feel it as much when I'm standing up, and I do the same motion.
Here's a little test. So sit down.
Okay.
And then bring that leg up and kind of cross it over this one. Yeah, yeah. And now do it again. Tell me if you feel it more or less.
Right. I feel it about the same.
Not the same. Try the other leg. It may not make a difference. I'm just kind of curious.
That one I kind of feel it like more.
You feel a little bit more?
Yeah.
Okay.
Like my bone was like, what's the word, like shaping or
Oh, yeah?
like scraping up against my knee, and then he cut it down, and I did rehab for everything, and everything was like good. My right, this kick's actually stronger than my left one.
That makes a difference when you take.
Or feels fine.
Do you feel anything now?
No.
Crazy, right?
Yeah.
Oh, I'm so excited. So you feel nothing. Go ahead, stand up now. This is so cool.
I was like, I come off. There you go.
Yeah, leave that one, the big one on there and see.
Do the big one?
Yeah, see how that does. Okay, now try.
It feels fine. It's weird.
So that's a really old video. We were navigating that. It's probably 8 years old, but we found that, the guy's wrist felt great if we just had cups placed on the scars from his knee. We ended up doing rehab like we did with a young boy, and we turned out it was more his ankle that was involved as we tensioned the fascial line on the lateral ankle. So it was really important as a boxer and an MMA fighter when their stance is where their leg is behind them and their wrist is away. So, we're using multiple physiological layers to look at this. This kid was a baseball player, but had a lot of tennis elbow problems. Turned out he had a lot of other injuries in other body parts. But you can see when we look at the nervous system, or I look at it in the nervous system, when a nerve crosses a crease, so you can see in this scenario, there's a nerve that literally crosses over the elbow crease. So when sometimes people have tennis elbow and they're not getting better, you might want to look at the sensory nerves that sit all over those areas, because they're the ones that are reporting things to the brain. So the tighter or more immobilized somebody is, especially with an elbow, say fracture or injury, you want to look above and below the crease and twist the skin and see if you can get rid of the pain.
Right here. So it's kind of like sore looking there. That's where your tender, if you press on it. So squeeze your hand for us. And you feel it. Where do you feel it mostly? Right there. Okay. So if we go that way and that way, try again. Click on the way. Do you feel it at all? No, but if I let it go, it comes back right away. So we're testing him. I think we have to go all the way around and all the way around. Try again, please. Much better. Nice. Weird. And then we'll let it go again. Feel it right away. Right away. Weird. Thanks.
So for the patients who have like grass burns, turf burns, things like that, where their skin gets shredded, this kind of scenario is going to happen, and they'll have pain that's unexplainable. But when they take off that top layer of that skin where those sensory nerves run, you might find that this approach will work better, because they can't get better if they have pain. But sometimes it's the very superficial layer that's reporting pain. And it's very different than a deep physiological layer, because the minute you take your hands away, they instantly feel the pain away again. So this works great at the knee, the wrist, the ankle. Especially with just trying light twisting to slacken the nerve as it crosses. And this is really primarily based on nerves that kind of exit above a crease and go below a crease. Just for time, we probably don't have time to do this. I'll just move on from this. This is just a wrist injury, a tennis player, but you can see he has pain, and then we fix the wrist and he does not have pain. There's a very different human inside somebody who has pain, who somebody doesn't. The sound of their voice, again, their emotion stuff that we already talked about, but the difference in the speed of motion is quite dramatic too. So this is a guy that is more of a recreational tennis player, but it's very important to him.
Is it good?
Yeah,
okay.
all along in here.
In that red area. Okay, what about is it just on the back, or is it coming back over? So just on the backswing, or when you're coming over to pronation as well?
Oh, sorry, I think I messed that up. Yeah, sorry about that.
Bad
Yeah,
on
like
the backswing now.
Yeah.
So once I'm going.
Yep.
But now I'm a lot weaker too. I can't even hang on to the racket as well as I used to. So now I've just
Gotcha.
changed my swing.
Gotcha, okay.
I've started to go forehand slice.
Yeah, gotcha. Yeah, feel pretty good.
Yeah,
Yeah, feel anything on it?
I mean, I feel it stretching, but it's not hurting.
Nice, okay,
No
good.
kidding. I would have never even tried that.
Get a serve in, we'll be good. I feel good? Yeah, do your serve now and see how that feels. It's as good as I.
So a lot of times we're looking at things very deeply. We're giving a lot of credit to joints and muscles. This is a professional PGA golfer who came to me after a TFCC injury. They found nothing. There was no tear. There was nothing. This is pretty typical of people that play golf. You've got to look at the mechanics of the joint, just like with the tennis players. They go into a lot of ulnar deviation. When you look at the joint mechanics, they often have to be fixed. Nothing is usually, you usually have a joint fault with a muscle imbalance on all of our athletes, but we've got to layer that top layer where the sensory nerves run, factor that in the course of the nerves. And this is just kind of a quick scenario on what that means for this particular golfer.
The wrist, with the fact that it sits lower than the forearm, and the nerve exits right here over the top. It'll come over here, it can get caught up on either side of the bone, down at the wrist crease, and this is one of the tendons. Yeah, so you kind of stuck on that tendon. So we worked out this tendon wraps when you wrap it around the golf club, and so that makes this section that you can see here tighter. So what happens is when you hit it, you're activating this particular tendon. It's called FCU. And so as you activate and go into that position again, that creates more tension on this. The nerve gets oftentimes either stuck here to the ECU tendon that sits over the top, or even at the side. So you can come up with a TFCC injury, but it doesn't show anything, but nobody's looking at the nerve that sits right here. And this nerve sits across the top all the way down to the pinky and the cider ring, but also drops down underneath here. So you could be hitting the golf club there all the time, but you're dragging the nerve from here. So since the Masters was on, I had to put that in. It's getting very exciting. But anyway, we've got to look at not just the joint as the problem, but look at the proximity of a sensory nerve over the top of that joint, as well as the exit point of that nerve from the motor nerve into the skin. So here's just, I think I have 2 more left. This is a tactical athlete. She's actually a police officer. But a lot of the tactical athletes need to also be included in this conversation, maybe not in Jamaica, but definitely in the US. But if you map where somebody's scar is, whether it's upper extremity or lower extremity, it will give you lots of information. So if we're giving the credit, well, I'm giving credit to the sensory nerves, all the pain receptors are in the skin layer. There's a lot in the lower part of the body, but mostly around the organs. But the skin layer has the highest number of pain receptors. So if you add a scar to your athlete or to your patient, you should factor in what sensory nerves will be affected by that. So if you imagine this scar, this is a ganglion scar, intersects the pink, the blue, the brown, then you've got at least 3 sensory nerves primarily that are going to be affected by this scar. And this shows very clearly. Just pathway, just show me where you feel the pain when you move. Yep.
Okay, so the pain, it kind of starts in here.
Yep.
All the way through up here, goes off.
She's pathwaying the pink pathway
Yep.
for you. Is it worse when you bend your wrist down or you do that? And then she adds a corner to that nerve. Yep.
Any kind of tapping.
She doesn't have enough
And
give in
over.
that nerve. Yep. So I got a scar there. And then do you have pain on this side too, or just?
Yes.
Yeah, okay.
Yeah.
All right, and then bring your thumb over for me. Does that make it any worse?
No.
Do your thumb tucked in.
Yes.
Yes, and then try and drop your wrist down a little bit.
Yes.
Yeah.
You see the area that
What do you
goes
feel about
white
that?
is where she has the most
here.
pain, and
Yep.
she shows that to you.
Gotcha, okay. So take this right here for me. All right, you can relax that. Okay, so do one more time all the way down.
Where
that
pain is
feel?
where it's stuck, and where it's
Yeah.
white is where
The
the
pain
nerve
on
is
that one too?
inherent and irritating.
Videotape it. Now I'm gonna remember that. So it's like, I almost got it. Skipped it again this way. Started here to here to bring everything that way. That way. With cuts up and down again. Do you have any pain or tension on that?
No.
No, perfect. Back and forth, you don't have anything?
No.
It is,
So we can very quickly get rid of pain if we focus on these things. I'm probably out of time, but for the people that are doing things with athletes that are using their hands, which is a huge amount of our athletes, whether they're bowlers or they're holding a cricket bat, holding a golf club, a tennis racket, any of those things. You want to really understand the proximity of the sensory nerves. The image on the right is it's a great article. It's an open access article. A, B, and C are the 3 points with the greatest amount of sensory nerve compression with the sensory branch of the radial nerve. If you have people who have thumb pain, index finger pain combination, I just did a professional ice hockey player with an index finger injury. He was off the ice for weeks and weeks. We got him back in 1 day by focusing on the points where the nerves become adherent. Number B on the right image is where the sensory branch of the radial nerve will become stuck to the EPL tendon. So that's a really important point to go to when you're treating your athletes. So I'm probably out of time. I can take questions when the time's appropriate, but thank you guys so much for letting me be part of this conference. So thank you again. Let's see if I can get rid of this.
All right, Miss Allison. Is it Miss or Mrs.? I'm not sure.
It's technically Mrs., but I don't know how long. So
okay, I'll just go with Allison if you don't mind.
I have freedom in my life, so I'm enjoying that.
All right, thank you so much. That was a rather interesting presentation. I'm sorry we didn't have more time to, hear some more, but thank you so much for presenting, gracing us with that wonderful presentations. Likewise, since we're pressed for time, I'm just gonna ask that persons put the questions in the chat, and then if you see any, you could respond as you see fit. Thank you.
Thank you.
All righty. So we're gonna go on to our next presenter. Guys, just reminding you questions in the chat and we'll have the presenters look and answer. Thank you. All right, so our next presenter is Dr. Paula Dawson, and I'll go ahead and read her introduction and then we'll get right to it. All right. Dr. Dawson, a pioneer for physical medicine and rehabilitation, psychiatry in Jamaica. She returned to Jamaica in 2008 to be a lecturer in the Faculty of Medicine at the University of the West Indies and a consultant at the University Hospital of the West Indies. She's the head of physical medicine and rehabilitation at UWI, and Dr. Dawson is the founder of Rehabilitation Institute of the Caribbean, the first multidisciplinary rehabilitation facility in Jamaica, and at the time, the only one of its kind in the English-speaking Caribbean. Dr. Dawson holds the distinction of being the only physician in Jamaica with US board certification in psychiatry, physical medicine, and rehabilitation. She received her medical degree in 2000 from the Faculty of Medicine at UWI after obtaining an honors bachelor's degree in the double major biochemistry and zoology, also from UWI. She subsequently went to Long Island Jewish Medical Center, North Shore, now Albert Einstein College of Medicine, New York, USA, where she completed 1 year in general surgery and then 3 years residency in physical medicine and rehabilitation/psychiatry. She then completed a fellowship in interventional spine, musculoskeletal, and sports medicine rehabilitation from the prestigious Northwestern University Rehabilitation Institute of Chicago in 2008, just before her return to Jamaica. Dr. Dawson's technical skills include pioneering work in fluoroscopic interventional spine treatment and spasticity management with botulinum Botox and phenol injection in adults and children with neurological disease such as cerebral palsy, stroke, spinal cord injury. She's a co-founder of the University of the West Indies Sports Medicine Clinic and one of the first group of UWI examiners for the Masters of Science in Sports Medicine for doctors and physiotherapists. She currently treats many professional athletes and was the team doctor for the Jamaica team to the IAAF World Championships in Berlin in 2009, World Indoor Championships in Poland in 2014, and IAAF World Championships in Qatar in 2019. She's one of the team doctors for the Jamaica football teams and treats many athletes that compete for universities, high and or primary schools. She has published in peer-reviewed medical journals and has spoken at several international and local medical conferences. Dr. Dawson has received numerous awards, including being selected as an awardee in the 2018 for UWI 70 Plus Outstanding Woman, UWI 70th Anniversary, 2012 nominee for National Disability Award, awardee for Jamaica celebrating 50, 2012 the 50 most outstanding Jamaican women in 2012. 2012 again, Caribbean Icons in Science Award and Caribbean Women in Science and Technology and Racers Track Club Outstanding Award for Sports Medicine. That was a windfall. And sorry, it's physiatry, not psychiatry. I'm so sorry, Dr. Dawson.
Oh, no, that's okay.
All right, so take it away, Dr. Dawson.
Thank you so much, Natalia. Thank you very much for inviting me to speak. Jamaica Association of Sports Medicine, you guys are awesome. So today I'm going to be talking about my fascial pain in athlete, and I am so glad that I'm going behind Dr. Pollyanna, and I think that was Allison. Both your presentations were excellent. So physical medicine rehab, I always like to start telling people what a physiatrist is. We're physicians of function. The field of medicine add years to your lives. PM&R will add quality to those years along with our rehab team. And it started after World War I when the soldiers were coming back with amputation from the landmines and brain injury from the explosion. And then in 1952, it became a civilian era of medicine where we had the polio outbreak. And of course, in physical medicine, rehab, physiatry, there are different areas that you can be a specialist in. You can do further fellowship training. I did mine in sports medicine, musculoskeletal rehab, and spine rehab. But of course, you can do all of the other things that I have listed there. I have nothing to disclose. So let's get into it. Myofascial pain in athletes. So this is highly prevalent in athletes and is often misdiagnosed as joint pain or some neuropathic pain. And there's a significant impact on the athlete's performance and recover. And it's very likely underdiagnosed because it's misdiagnosed, and it can lead to impairment in the performance and the function of the athletes, early retirement, and it's muscle-based pain with trigger point. Now, let's establish the diagnosis of what is myofascial pain. I'm sure everybody has heard of it. So pain that originates from myofascial trigger points in the skeletal muscles. So it may stand alone or in combination with other pain generators. So what are these myofascial trigger points? Well, I'm glad you asked. So there are these tiny little pea-sized area in the muscle belly or in taut bands. And taut bands are these long, ropey, rubbery feeling that extend the full length from the insertion and the origin of the muscle. So I'm sure if you were to feel over your neck right now in your traps, supraspinatus area, you might feel a knot. That's a trigger point, right? And usually corresponds to the region of motor end plate. That is the taut band and the myofascial pain. So here we have a picture of a taut band. So this is the taut band from the origin to the insertion, and the trigger point is usually within the taut band. It's an area where you have excess contracted myofibrils. So there's due to contraction of a group of muscle fibers and extends from the trigger point to the attachment of the muscle. So a lot of times we'll see it in the traps. We can also see it in the gastrocs. Sometimes we actually see it in the adductors in our athletes, especially the ones that have external rotation when they run, and I'll come to talk about that. But there are these ropey areas, and you can elicit a localized twitch response. And this twitch response we can use to help us to figure out when we're doing the treatment. And they're usually electrically silent. So the trigger points are tight areas within the muscle tissue. It can cause pain anywhere in your body. It can be in your buttocks, your glutes, your everywhere. And I'm going to show you a slide of the listed areas that we'll commonly see them in athletes. But before I get into that, I want to tell you a little bit more about these myofascial trigger points. So they can be quiet, they can be latent, or they can be active. I have a latent one right in my rhomboids, and every now and again, it just gets active. So the latent ones are those rubbery knots that you feel that are not painful. I'm sure you have some of them in your shoulders. And then when you sleep bad one night, you wake up, you have a crick neck, or you have a pain in your lower back. And so the latent ones can convert to become active. And the active ones are tender, and they can cause pain. Sometimes when you have that pain and your athletes and you touch them, you elicit the pain. And we call them trigger. Why? Because they can refer pain to different areas in the body. It causes loss of range of motion of that particular muscle, and it may have satellite trigger points around it. You may have a main one, and you might have some little ones around it. The satellite ones often develop in the region around the active myofascial trigger point. And so you may even have some at the attachment, right at the attachment, the muscle insertion. Those are painful because they're closer to where you get the high tone and the high pull in the muscle. And so they often develop at either end of the taut band. So what are the common causes of myofascial pain in the general population? Then we're going to come to the athlete. So it may be from direct or indirect trauma, wherever in the body. Spine pathology. So the spine is a culprit. You know, when you have myofascial pain around the spine, with the paraspinal muscles up and down the spine, the traps and down in the glutes, the spine is one of the main culprits. Exposure to cumulative and repetitive strain, as we see when our athletes are always working out, postural dysfunction. We're going to talk about some scoliosis, leg length discrepancy, or they're just physically deconditioned and they're trying to push themselves. In the athletes, it's from overtraining and repetitive loading, or poor and efficient biomechanical posture or form. There may be muscle imbalance, muscle overloading, and inadequate recovery. And there's one that I'm going to add. A lot of our athletes, whether student or professional, they're gamers. They sit in the couch. I have had so many unusual pain presentation, not related to sports, but related to position, where they're gaming with their legs flexed under their body or their toe twisted under their leg, under the foot. And so we're going to get to the history of looking at different causes outside of the sport itself. But what is it? What is the pathophysiology? Yes.
Pardon, can you go to the slideshow? We're seeing all the stuff. We're
Oh,
not seeing the
I
full
thought
slideshow.
I was on slideshow. Let I escape. You know what? Let me I think because I have my extra monitor.
Oh.
Let's try this now. I think I had my extra monitor on, but it was on my extra monitor. But how is that? Is that better?
Yes.
All right. Yeah, my secondary monitor had it as a full slideshow, and this one had it. Okay. All right. So the pathophysiology, you have these micro trauma in the muscle, and what happens? The calcium leaks out of the sarcoplasmic reticulum, and what you'll get is persistent contraction in these muscles. So if you have persistent contraction in these muscles, you're going to have an area of infarct where there's energy crisis, there's loss of ATP, and you get ischemia, hypoxia, and acidosis in the muscle. And then you get scarring in the muscle, and you get these ragged red fiber. And in addition to that, you have release of endogenous chemicals. So it's like a soup, a milieu, a soup of all sorts of chemicals in the area. So you have histamine, you have serotonin, you have bradykinin, and all these are chemotactic agent for pain generation. So the alpha motor neuron, let's move this one out of the way. Way down to the bottom, at the top, right? So the alpha motor neuron, you get dysfunction. So dysfunction at the motor end plates, where you have this release of excessive amounts of acetylcholine, repeat fiber action potential. The action potential will be coming in and causing consistent contraction, muscle hyperactivity, and you get this biochemical cascade, as I mentioned before. So motor abnormalities that occur, you get hyperresponsiveness, you get delay relaxation, you get increased co-contraction. I think Alison mentioned that increased co-contraction, you don't get relaxation with the antagonist, so you lose that coordination, and you have abnormal firing patterns. The clinical presentation that you see in these athletes, they come with complaint of deep aching pain, reproduce with palpation, and they tell you, oh, I'm so stiff in this area, this leg doesn't move as far as the other leg, I have decreased external rotation of my hip, or dorsiflexion of one ankle is less than the other, especially if they have it in the gastrocs. And there's motor dysfunction without any atrophy. And so the common clinical sites will be the trapezius muscle, the scalenes, the levator scapulae, especially the quadratus lumborum, piriformis, glutes medius, and gastrocs. If you feel down now by your medial gastrocs, you may even find a little tender spot, and that's a trigger point as well. So myofascial pain, it may be localized or it may cause referred pain, usually in a non-dermatomal distribution. I always find a myofascial pain quite interesting because sometimes when I touch, I don't know if you've ever found where you touch like your temporalis muscle and you feel a pain in the opposite side, which doesn't even make anatomical sense. It could be a myofascial band connection through the fascial plane. So it may also mimic radicular pain. A lot of the ones around the neck can also mimic radicular pain, or it can mimic joint pain. So that's where you get the misdiagnosis, especially if it's around the knee or around the elbow. But there are predictable patterns if you know which muscle the myofascial issue is. Here's the sternocleidomastoid trigger point, which can refer up and down the neck itself, and you can even get it around your periorbitally, down into the chest. The trapezius and the cervical paraspinal, you can see where it can refer down the neck, and you might think it's radicular pain. The scalene, especially for your throwers, and especially for the athletes that don't have good form when they're doing their sit-ups and they're craning their neck, they can get trigger points in the neck and refer down to the hand. You might think, oh, they have some radicular pain when they don't. And again, in the lower back, very, very common in our athletes, that quadratus lumbar just tighten up, and it can give you what we call a listing or a pelvic obliquity. A lot of times you guys have to do the manual adjustments. I mean, we have some amazing massage therapists and physical therapists who are well versed in manual manipulation, and they sometimes correct this. But I'm going to tell you, if you don't correct the underlying problem, they come right back. And of course, the iliopsoas is notorious for the tightness. So how do you diagnose this? Well, primarily a clinical diagnosis. History is important. As it relates to the sport itself, you want to know what sport they play, the frequency of the training, if they've increased the training, if they've increased the training load, or if they've changed services. So you want to ensure that. But I wanted to add the gaming position because I'm seeing more and more social media scrolling, positioning. A lot of them, I find that they're having shoulder pain because they lean down on their left shoulders and they're scrolling with their right fingers, and they're getting rotator cuff issues without even being a throw or any inciting event around the shoulder, but just from bad position. So you have to do an examination. Dr. Blake, you can mute, please. Or if you guys can mute Dr. Blake. Right. So you want to do a proper examination. And of course, there's no gold standard imaging because, of course, it's muscular. And sometimes with ultrasound, you will not see anything at all. Misdiagnosed for tendinopathy, misdiagnosed for muscle strain or nerve entrapment or facet or joint pathology, especially if it's axial spine pain, or even a strain when it's in the muscle belly itself. And how do you treat it? Well, it's multimodal, of course. And so the main thing is you have to treat the underlying dysfunction. What is this dysfunction? The most widely accepted strategy is treating the underlying dysfunction. So you go to the root cause. Is it a limb length discrepancy? Is it that they have started overtraining? Are they doing too much repetitive of one thing without adequate rest time? These are some of the things you want to do for the training. And of course, if the root cause is not properly treated, guess what will happen? The trigger points will come back, they will reactivate, and the myofascial pain will persist. Treatment, always eliminate factors that perpetuate the motor dysfunction. For example, we talk about our athletes, poor body biomechanics, our training techniques. Is there an anatomical variation in this athlete? Is there a leg length discrepancy? Scoliosis, I've had an athlete where, and this is interesting, I have had so many athletes where they have adductor strain or myofascial pain because their foot or the lower limb is externally rotated. And it's externally rotated, you know why? Because they wear boxers and the penis and the genitalia is not held in position, so they have to externally rotate to walk wide of the penis or the scrotum. And so when they're supposed to be using their hip flexors to run, they're using their adductors to run. And so this is another anatomical variation that you may, it's more like behavioral variation because it's not a true tightening or hip pathology. Is just that their body has no external rotation. It's usually one leg, it's usually the left, interestingly. Another issue might be scoliosis. Well, as you know, scoliosis is curvature of the spine. And if there's curvature of the spine, one set of paraspinal is going to overwork more than the other. Of course, you have vocational overuse, which I mentioned before, the gaming station. Patient education, you have to teach these athletes the frequency of stretching and regular change of position, even especially when they are doing outside of their own training, right? Their sleep positions are important, and of course, the hobbies that they do. So what are the treatment options? Manual therapy, we are, the sports medicine group in Jamaica are very versed at myofascial release, acupressure, ischemic compression, trigger point pressure. We have soft tissue mobilization, and there's massage. Of course, there's dry needling that will elicit that local twitch that I mentioned. And once the local twitch response is elicited, you tend to get relaxation of the muscle. In fact, sometimes when I'm doing trigger point injection, which is on the next slide, you can actually feel when the trigger grabs the needle and you can't get it out, right? So dry needling reduces the spontaneous electrical activity and improves pain and range of motion. So injection, sometimes I inject anesthetics. Corticosteroid can be used, and I'll talk about it in the next slide as it relates to the washout period for athletes in terms of world anti-doping and prohibited lists. We can use saline, which is prolotherapy, or dextrose water, another form of prolotherapy, or you can use ultrasound guided techniques for injection. And you can see here where the needle is going right into the trigger point, and sometimes you can just go in and agitate the area and you can unlock those knots. Exercise, of course, is important. Progressive loading. You don't want to load too quickly because the muscle is going to go into spasm. Neuromuscular control, PNF, is a good way of having the muscle to relax. You want to correct the kinetic chain. If there's some deficit in the kinetic chain, of course, stretching, strengthening, and posture correction. But shockwave therapy, shockwave is very popular because it creates neovascularization. Of course, remember I told you with the myofascial pain, there's ischemia. The constant contraction of the muscle, the myofibril, it causes occlusion of the capillaries and causes point ischemia, which will lead to scar tissue and all that milieu of chemotactic agents which will bring in the pain responses. But shockwave is known to cause neovascularization. We can use TENS machine, we can use heat, ultrasound guide as well, which is therapeutic ultrasound, different from diagnostic ultrasound. You can use cupping, you can use scraping. And of course, we just learned that you might be able to use also cutaneous stimulation, as the previous presenter mentioned. But of course, prevention is key. Always screen your athletes. Make sure movement is well monitored, that their form is properly. You want to have equal balance in terms of strength. One side shouldn't be weaker than the other. They need to warm up, they need to cool down, and you want to load them progressively. And you want to, of course, ensure that you don't load too quickly, right? Especially for our younger athletes. Hydration is key, and I should have included nutrition, but my next presentation will talk about nutrition and, of course, recovery optimization. Thank you very much. Hope I was within the 20 minutes.
Wow, I didn't even have to stop the timer. Thank you, Dr. Dawson.
You're welcome. Let me stop sharing.
Okay, and I think we'll have time for a few questions. Any questions for Dr. Dawson before we move on to our next presenter?
So Dr. Dawson, how you doing?
I'm good. How are you, Jonathan?
Man, I'm great. I'm great. I wanted to ask, how do you do your assessment on athletes that have hamstrings or latissimus dorsal injuries or the erectors in their backs? How do you assess that?
Well, the assessment, as you know, definitely start with the history. So it depends. Sport specific. A lot of us treat primarily track and field athlete, but of course there are other sports athlete, and common things are common. So the assessment for, you ask hamstring, of course you want to first find the history. Did the pain start during training or during a race? Is there pain only when you compete? Is there pain only when you are training? Is there pain at rest? So those are the things that will key you in. And for the hamstring, of course, it's basic. You want to ensure range of motion. You want to see where the pain comes on. As we're speaking specifically now for myofascial pain, outside of you having a suspicion of a tear, and the tear will be in keeping with the history, you can clinically palpate the trigger point. The thing with trigger, even in the examination, if you apply enough acupressure, you get decrease in pain. Whereas if it's a tear, when you apply more pressure, it's more painful. So that's one of the things I use to differentiate if it's a tear in the hamstring or a trigger point in the hamstring. I hope that helps.
Yes, thank you so much. I appreciate that, man.
You're welcome.
And I saw how much accolades you have. I would love to, follow in the footsteps one day.
God bless you. God bless you.
Okay. Do we have any more questions? Don't all shout at once. I guess you were very thorough then, Dr. Dawson.
No, I'm seeing one in the chat.
Hello?
I'm seeing one question in the chat by Miss Kathleen Taylor Hennis.
Oh,
Our clinicians
Oh, okay.
Oh, I was just it's such an excellent. Can you hear me at all?
Sure, yes, go ahead.
Yeah, what an excellent presentation. Thank you so much. Just there's so many things, but one thing was just wondering if clinicians in Jamaica finding the addition of shockwave therapy very helpful for their athletes and other patients.
Definitely. Definitely. And they have this extracorporeal shockwave therapy. It's very commonly used now in Jamaica, especially within the last 5 to 6 years. They also have this other thing, EMTT, extracorporeal magnetotransducer therapy, which is another thing they say along with shockwave work. But shockwave therapy does work. And I'm sure all the physical therapists here who use it can attest to that.
Thank you so much.
You're welcome.
All right. All right. We'll go with one more question and then we'll move on to the next presenter. No questions?
All right, yeah, not seeing any more right now. So you can go ahead.
All right. So our next presenter, I'll have Dr. James do the introduction for presenter. So take it away, Dr. James.
Okay, thank you so much, Natalia. So our next speaker is Nicholas R. Powell. He is an AASP certified mental performance consultant and CEO of the Mind Game Consulting, specializing in the psychological aspects of injury, rehabilitation, and return to play. His work focuses on integrating mental performance strategies within multidisciplinary sports medicine teams to optimize athlete outcomes, adherence, and overall well-being. With over 15 years of applied experience, Nicholas has supported athletes competing at the NCAA Championships, World Championships, World Cup, and the Olympic Games, serving as an independent consultant across 3 Olympic Games and 3 World Athletics Championships. He collaborates closely with athletic trainers, physiotherapists, physicians, and coaching staff to address key psychological factors in injury recovery, including confidence, fear of re-injury, identity disruption, and rehabilitation engagement. His international work includes partnerships with Puma, supporting elite athletes in Jamaica and internationally during the last Olympic cycle. Powell currently works with the Jamaica Senior Women's National Soccer Program, the Reggae Girls, who are doing extremely well. So please come out next week, Sunday, and support, contributing to mental readiness, resilience, and the development of psychologically informed return to play processes. In addition to his applied practice, Nicholas serves as a lecturer at both McKendree University and Southern Illinois University, Edwardsville, in the field of sport and performance psychology. Professor Powell's focus is to deliver clinically relevant, high-impact information that equips sports medicine professionals with practical tools to integrate psychological care into injury management and athlete support systems. And I think that this talk was very important, and we're happy that Nicholas could take some time out of camp to come and share with us today, because a lot of times we have athletes and sometimes we're telling them that it's in their head or they can push through. And I think we really need to get a better hold on that. So Nicholas, we look forward to your talk. Thank you.
Okay, thank you very much. Can you hear me?
Yes, we can hear you fine.
All right, sweet. Okay.
And
So-
these are dirty.
Yes, we can
These
hear
are
you.
all white, or these are mixed?
Okay. Dr. James, thank you. All right, so the biggest reason I got into sports psychology mainly because most of the time we see our athletes perform well going through the developmental phase, but when they get to the major championship where they have more importance on, a lot of time they underperform, right? And so I went into sports psychology because I wanted to understand what was going on and help these athletes navigate through that. Most of the time athletes don't perform well is because psychologically, not because they're not properly trained, prepared physically, not because they don't have the talent, not because they don't have the equipment, it's because of the psychological component of it. And as a GC Foster trained coach, certified coach, and former high school teacher and coach in Jamaica, I know our culture, especially throughout the Caribbean, doing this job over the last 15 years. I understand that most of the time we don't spend a lot of time on the mental side of performance. So especially when it comes to athlete injury, and I could be wrong because I haven't been here locally in a while, but most of the time we're taking more of a biological and most of the time we're taking a biological approach to injury treatment and not focusing on the psychological aspect and the social aspect. I could be wrong, but I definitely want to put that disclaimer out there. It takes for the athletes, in order for the athletes to take their performance to the next level, the body has to be exposed to stress, right? That is what helps them to improve, to push their body. If it's too much stress, then it can cause the potential of injury. I have a list of common factors that influence injury, that could be stress, anxiety, anger, hostility, and depressive mood. If we don't spend time to get to know our athletes and take a proactive approach to care, our athletes could be experiencing any one of these four factors, and we don't address it, which can put them at risk of injury. All right. Here's the biopsychosocial risk profile. We have the biological, we have the physiological, we have the psychological, and the social. Biological, we know that overtraining can influence, can cause the breakdown in the body and can lead to injury, fatigue, menstruation, exposure to poor injury. On the physical aspect, it can be poor conditions, it can be anxiety in the environment. On the social aspect, it could be the training. There are times when coaches might not necessarily have the right approach to how they coach their athletes, because everybody have different ways in which they get to even the same goal. And then the psychological aspect, like I mentioned, that is where a sports psych come in. I'm gonna ask you, and you can put it in the comment section. How many of you actually, when you're treating your athletes, actually implement consider the psychological aspect of treatment? To my understanding, not very many people use it. So I would definitely say consider that. Okay. Sorry. So when an athlete is exposed to stress, there's two things that happen. They have what we call the primary appraisal, is where they assess to see, evaluate, do I have what it takes to execute this skill, right? Because this task is going to be challenging to me, and the first thing that we do is we assess it. The elevation with the heart rate is what we call state anxiety. So everybody experiences state anxiety based on how our interpretation of the stressor or the task that is required of us determine how we move forward. So if when we assess it, I need to run a 4x4, and when I assess it, I think of, I have everything that it takes. I've put in the proper training. I'm in good shape physically. I'm doing well. Then we shift. It shifts to the secondary appraisal now. Do I have the resources in order to execute, to win this race, or whatever the outcome that I'm desiring? So there's the primary appraisal, where is I have this thing that I need to do. Do I have what it takes? And then the secondary appraisal is, do I have the resources in order to handle the challenge and be successful? If we don't, that can cause a stress response on the athlete and cause them to go into panic mode or yeah, our anxiety, right? Where we come in as sports psych, sports and performance consultant, you'll hear mental coach, sports psych, sports psychologist. I am not a sports psychologist because I don't have a doctorate, but I am a certified mental performance consultant. So you'll hear that term being used, right? But where we come in, we help our athletes on these three components where we're helping them to cope with the behavior. When they're exposed to stressors, how do they handle it? I was talking to a group of athletes recently, and when I asked them how do they relax, some of them talk about doing video games, some of them talk about going for a walk. If you're in a situation where you're not allowed, you're not able to expose to that, if you don't have the proper mental skills, coping skills to help you, you're going to go into that anxiety mode as an athlete because we now become a little bit more nervous, and that can cause us to doubt, do I have the ability, because I'm not able to control the feelings that I'm having right now, which is the physiological responses. Another thing that we do is teach our athletes psychological skills, so mental skills. We are teaching them visualization, goal setting, breathing exercises, all different tools we are providing them with to calm themselves down so they're better able to approach the task that is given to them to help them to navigate so that it doesn't take away from the training that they have done. Because most of the time, athletes are being challenged and being put in stressful situation. It's in a controlled environment. So it's practice. Unless they're being exposed to stressful situation in terms of simulation of competition to help them deal with that, sometimes we put them into that situation, and it caused them to panic and get nervous, especially when they perform well at the local level. And then we have our athletes go to a major championship and they now think that they need to do something different. If we don't have the proper mental skill training to help them navigate that, you'll see them go on that level and underperform. And then who are the people that we are putting around them for social support? So whenever I'm working with our clients, is we want to make sure that we are identifying people to provide social support for them to make sure that they simulate the competition environment, that it still feels safe as a practice environment. All right. One of the things that I love, especially in the Caribbean, we are including more people into the coaching staff, and I work mostly in track and field, but we're including more people into the team, the performance team with the athletes. So for the physiotherapists, for the massage therapists, for the coaches, for the team physicians, these are just a few things that you can look to identify when an athlete is struggling psychologically and experiencing as seeing what they are required to do as a threat instead of as a challenge, right? When we see it as a threat, it's something that's going to harm us. When we see it as a challenge, it's something for us to rise to. If we're not simulating that, then when they are put in a situation, when you call a sprinter to come and run the 4x4, if they don't believe that they have what it takes when they did do their primary appraisal, they'll think that this is something threatening, and they start think of all the negative things. And these are some of the behaviors you'll see. They'll have difficulty sleeping if they know the night before, lack of focus, sometimes they can't concentrate, they withdraw and isolate from themselves, and some of them even use substance. And I'll come back to that when I start talking about the injury, right? And then the physical aspect, they'll feel sick. I got to go to the bathroom. They're sweating profusely, headaches, increased muscle tension. Increased muscle tension contribute to them also being at higher risk of injury. And then the psychological, when we know our athletes, so while you have the athletes on the massage table, having conversation with them, you'll hear that the negative thoughts about what they think may go wrong, or them not being prepared, inability to control negative thought process, using unable to concentrate again, and then self-doubt. They'll execute a lot of that. When I'm working with my clients, I want to make sure that everybody on the team know where our goal is. Because when you're working with the athlete from the minute they get off the bus till the minute they get on the track, everybody that put hands on them, even their teammate, should know what their goals are and how to help support them and encourage them through that process. So that's one of the things that I work with. All right. So here's the stress response. So when the athlete become extremely stressed, it increased muscle tension, narrow peripheral vision, increase the distraction, and decrease ability to plan or execute movement patterns. When this happens, we see the athlete putting themselves at risk, and you see them have some, what we call it in Jamaica, say them clumsy, or they make some simple little mistakes and cause an injury, right? If they have increased stress for a long period of time, it can cause the release of cortisol, which also suppresses immune system, so the body doesn't recover as fast through exercise when you stress it in order for them to take their performance to the next level, which also contribute to, if the body is not recovering well enough, then that's going to put it at higher risk of sustaining an injury when they're out there competing. And then it slows down recovery of the physical stress process. All right, so when the injury happens, right? So when the injury happens, there are different reasons. So you have personal factors that may contribute to it, and you have situational factors that contribute to it. Right here where you see this core is the ABC that goes on during that time. So you have the A is affective, affect or emotional. Then you have the B, which is a behavioral, and the C is a cognition. So this core, this dynamic core goes both ways, right? So the clockwise is more cognitive. Based on my appraisal, when an injury happens, based on my appraisal of the injury, it's going to impact my emotions, my effect, which is going to later on influence my behavior, right? As it comes to recovery outcome. And then also it goes other way based on my cognitive appraisal. Effect, I think I made an error with that, but affect it goes the other way. So based on my emotions, how I feel about it, it's going to affect how I think about things, and it's also going to affect the behavior. All right, so here it is. So the athlete's personality, the history of stressor, coping resources, if they are already exposed to those skills, those mental skills, when an injury happened, they're able to appraise it a lot different than if it's the first time. And it depends on the importance of it. So for example, one of my students at the university got hurt in her senior year of playing soccer. So now, because of the importance she had on what she expected of her senior year in football, it impacted her more negatively than somebody who would have more time to recover and play and still be able to represent the school and play at the next level. So we have to keep those things in mind when we are working with our athletes. And if we're not incorporating the psychological aspect during that time when that injury occurs, it can cause more stress on the athlete, because now the injury also becomes a stressor for the athlete. and impact the appraisal process. All right. When an athlete goes through injury, if we don't understand the grief process, a lot of the times we will try to step in and try to rush them through the process of what it is. And by now you should be over it, or they don't include the psychological aspect. And when the athletes go through the depression and they're like, we can't understand, you're physically able to get back, but or you're on track to get back, but you're still depressed because you're dealing with this. As sports psych, as mental health therapists, our job is to come in and help the athlete accept where they are and then figure out a plan moving forward and give them enough time to navigate through it. We can't rush through the process. So we'll see athletes who are fully recovered, but they're not able to go out on the field and perform the way they're supposed to perform. And we can't understand why, what's going on. Is because they haven't gone through the grieving process properly, or they have been pushed through it and they never got a chance to really deal with what's going on. All right. In the university system in the US, most of the time, the athletic trainer, when an athlete is injured, most of the time the athletic trainer or the physical therapist is the first point of contact. Depending on how serious the injury is, if they need to see a doctor or whatever, get treated by a physician, those are the primary rehabilitation team. Most of the time, we don't have a proper structure when we're putting together the secondary rehabilitation team, which is why I want you guys to start considering these different areas when we're working with our athletes. We'll think about the athletic coach, we'll think about, very rarely we think about the sports psych, the clinical psychologist or the psychiatrist. A lot of time we don't think about the sports nutritionist, the dentist, the pediatrician if it's a child. We'll look at the biomechanics. But most of the time when we're putting together the team, we're just considering the physical therapist, the doctor, if it's needed, and the athletic coach, and then maybe strength and conditioning coach. But these are different components that are needed when that need to be considered when we're working with our athletes. For example, a basketball player get hurt, and now they're not able to. Their identity is as an athlete. When they're not able to compete, either practice, a lot of time if they don't have the proper mental training and feel like they have the proper mental support, their appraisal mindset may go to, nobody cares about me. This is the worst thing, and they start having all these negative self-talk. And if we don't have the proper support around them to help them navigate through it, they may not be able, it may affect the way in which they show up to practice, to rehab, and that can interfere with how quickly they progress through the process and get back into treatment. I was talking to one of my track athletes, and he shared with me that he had just gotten hurt and nobody came to check on him after he got out of the hospital. So everybody was there when he got hurt. Nobody came to check on him during that time. Psychologically, start saying, nobody care about me. Maybe I'm not good enough. Maybe this is the end of it. And if we don't have the right support. So one of the things we had to put in place is, who is going to be your contact person to help you navigate with food, like get food and stuff like that? Who is going to help you navigate to get to treatment because he was on crutches? When can we set up a session with the coach to help the coach check in on the progress, see what's going on, and let the athlete know that they are valued, right? Because when I know that I'm valued, then I feel better about myself and I'm able to navigate. I just watch him compete indoor and he killed it indoor and getting ready for outdoor. because we were able to put a support system around him, parents, girlfriend, family and friends, because sometimes as family and friends, we'll see the athlete struggling and don't know what to do. But because we don't understand the psychological component of it, we're like, I don't know what to do. And the support system can get frustrated because the athlete is getting aggressive when they're struggling with not going through the process. So we want to make sure that we are putting the mental coach into that process to help develop the system. Some of us may not have the access to sports psychology consultants. So one of the things that we can do is find another athlete to meet with with the athletes, somebody who has experienced injury, has gone through the process and has recovered and is now competing well. If we can identify them and bring them in, if you don't have the person in directly in front of them, we can find athletes example on the internet. Back in my days, we never have that stuff. So now you can find athletes on the internet that they can follow them, their system, their story, and use that as motivation to guide them, navigate through that. For some organizations, they have access to support groups where they have a group of athletes that they can come in as they're going through the rehab process and they're able to encourage and navigate. The performance group side, that is where the sports psychology consultant comes in and work with the athlete to help them navigate through this process and focus on developing psychological skills through the process, like goal setting, journaling. Because when an athlete is going through an injury recovery process, they're thinking about the pain that they're feeling right now, right? And it doesn't matter if they're making progress, if they're moved from 90 degrees to 150 degrees, all they know, the pain feels the same and they can't manage it. But when they track in their journal, they use the journal as one of the tools that we work with our clients and help them to track the progress. They can see the progress and now they can feel the need to challenge themselves, because that pain feels the same no matter if it's at 90 at times or it is at 180 or 150, right? So we want to make sure we work on that. And then also find ways to get the athlete to talk to a therapist one-on-one, a counselor one-on-one, because don't assume that because they're progressing, they're going to be mentally ready to compete, even though they are physically prepared, right? And just to wrap it up, you want to make sure that you build a rapport with your athletes from the get-go. So most of the time athletes come to physios is when injury happened. As physios, sports med professionals, we want to make sure that we build relationship with our athletes, because when an athlete is injured, seeing an unfamiliar face can be a trigger for them. It can throw them off. But when you build a relationship and rapport with them, it's a lot easier for them to, when they're injured, to come to you. You also want to be proactive in your approach with stress management. So we want to make sure that we're including a sports psych, a mental coach to help them navigate through this, because we don't want to take a reactive approach, and it's unfortunate and it can be expensive, but it's a lot more expensive if we don't bring in the mental coach early when they're healthy, so they can teach them the things that they need to do, or even bring in the physical therapist to teach them on habits, do the assessment. It's going to be less expensive than when they actually get hurt and now they have to come in and learn that stuff, right? Make sure that you're doing the assessment early, so you're checking in with your athletes, seeing where they are mentally, as coaches, as sports psych, as physical therapists, as physicians. Make sure that you're checking in with their mental well-being, and then figure out ways to reduce the stress level so their body can heal and recover quicker and reduce the risk of them being of them being injured. And then make sure that we have a comprehensive care team structured for them before the injury happens. So, for example, with my athletes, once they have set their goals in sports psych, once they have set their goals and what they're working on, their strengths and all that, one of the things I ask them, who are the people on your support system, on your support team? And they're like, mom, coach. I'm like, okay, yeah, those are good. Who are some other people that can, who, when you're stressed with mom or coach or whoever, you can go talk to those people. When you're, because anybody don't get frustrated with their coach. Let me not say that. That's not good. But if anybody don't get stressed out to their coach, they need to tell me what the formula is, because everybody at some point gets stressed out. Who are the people I'm talking to that's going to help them navigate and have a clearer mind as they're going through? And then remember, consider a biopsychosocial model when treating your athletes, because I think I was rushing through it where I talk about when an athlete, right here, when an athlete is injured, they go through three phases of three reaction: the reaction to injury, reaction to rehabilitation, a reaction to return to participation. And if we don't have the proper support around them during that phase, during those three phases when they're going through it, it will cause them to delay the process of recovery, and possibly when they're done recovering, you still have to go back and include the psychological aspect, because they're afraid to go out there and challenge themselves because of fear of injury again, and fear of possibly never playing or performing again. And even when an athlete is injured and have to retire, we also have to provide a psychological component to that, to help them to navigate that, especially, and not just when they're injured. I work with athletes who are, when they're transitioning from high school and they're no longer doing sports, or transitioning from college and no longer doing sports because they don't feel like they're at the level to get there. That can cause psychological impact and cause injury. And then also athletes who are transferring from competing professional to retiring from sport. This has been their identity for a long time. That can also cause depression. And as sports psych coaches, physio, we are close enough to see the athletes and able to identify and provide a referral, as Dr. Polyan recommended. Refer. If you identify that there's something going on, please refer the athlete for support, because that could be the difference between them moving on successfully and them going into a spiral and possibly hurting themselves, addiction and serious depression. All right. Any questions? No. All right.
But excuse me, Mr. Powell, I have
Yes,
one
sir.
question. Because you are, of course, focusing on the athletes, which are, that's still part of this webinar. But I just made a point in the chat that coaches get stressed out too.
Yes.
So how do you treat with that?
And it's the same thing. We work with athletes. So I know I use sports athletes, but it's also human, right? So it's not just sports psychology that I do, it's performance psychology, and coaches are performing also. So we also provide consulting for our athletes, for our coaches, for the entire team, to make sure that they're in a good mental space so they can provide the support for the athletes.
Okay, great. Thank you.
Any other
Not
questions?
seeing any more questions currently. All right, that might be it for the questions for now, at least.
Okay, thank you.
Okay, thank you, Mr. Powell, for that. I really love the holistic and integrative approach, especially the mental side of it, very important. So thank you so much for your presentation. It was thoroughly enjoyed. All right, before we move on to our final speaker, I just want to let you guys know we have a quick giveaway at the end. We have two giveaways. So stay tuned. We have some questions. I hope you're paying keen attention to the previous presenters because we have some surprises at the end. All right. So because we gave such a nice and lovely introduction, we don't need to do it twice. So we'll have Dr. Dawson back on the floor. All right, Dr. Dawson, take it away.
I was here talking to myself, not realizing that I was muted. Okay, so I'm gonna ask you guys to let me know if you can see my proper view, the presentation view. Not hearing.
Yes, it's fine.
Okay, wonderful. So we'll continue. All right, so chronic pain management in the student athlete. So a lot of people call me the pain doctor. I am not the pain doctor. I am the no pain doctor. All right. So we will progress. Again, skipping over this physical medicine, rehab, physiatry. A lot of people call me a psychiatrist, but I'm not. I'll leave that to Nicholas and all the sports psychologists to take care of that, and Dr. Poliano. Although she's a pain specialist, but I'm sure she has to deal with a lot of cognitive issues, which is very important when we're talking about chronic pain. Nothing to disclose again. So today, again, I'm going to be talking about chronic pain. So I'm going to define chronic pain in athletes and in general, and then recognize common presentations along with common injuries for the student athletes. And then I'm going to talk about some biopsychosocial mechanism that's relevant to the athlete, and then outline some evidence-based assessment and the differential diagnosis. But ultimately, the treatment for chronic pain is a multimodal treatment, and return to play is a team approach. So common causes. So the prevalence is common across primarily endurance and contact and overhead sports. Clinical results you will find in athletes that have chronic pain, you're going to see that they have decline in their performance, they have some psychological stress, overuse injury, and some of them end up sadly going to early retirement. And a particular important thing to remember is that we're dealing with student athletes and they have physical growth plate issues. So their growing bodies, especially around the growth plates during their growth spurt, are very susceptible to injuries, especially overuse issues. But by and large, chronic pain is a complex pathophysiological system where there's an interplay with the tissue, which is the actual injury, then with neuroplasticity, which is upregulation, which I'm going to talk about, and then the psychological factors. So in the student athletes, they're still growing, so they have these open physis, they have an immature musculoskeletal system. Of course, in addition to being pressured to perform as an athlete, a lot of them are still pressured to perform academically, and they are more vulnerable to overuse injuries and maladaptive coping. Of course, growing pains sometimes is a misdiagnosis that is used for these athletes that have chronic pain, but the injury is likely as a result of overuse related pain in the thighs, back of the knees, or calves. And of course, there can be gender predilection. Females tend to have more chronic pain than males, and you see the percentage there 45 to about 34.9%. So I'm just going to mention these quickly. I'm not going to go into detail. So just I want to mention growth plates issues that you can see around the knee. You have Osgood-Schlatter. Everybody knows what that is. It's a pain over the pubic tubercle, commonly in running and jumping athletes from tight quads and some other stuff, and can be very chronic. Sever's disease, we don't see it as common. Calcaneus tubercle, likely in the jumpers, the high jumpers and the long jumpers. Little league elbow, medial and lateral epicondylitis. And then, of course, you have the proximal humeral growth plate overload from throwing athletes. Some of our gymnasts, the young girls, will have pain in their distal radius around the growth plates. And then you have this thing, we call it SUFE in Jamaica, which is slip upper femoral epiphyseal plate, but in America they call it SCFE, slip capital femoral epiphysis pain. And that's an injury to the hip, seen in young adolescents. And of course, commonly seen in our kickers, like footballers and our runners, the osteitis pubis, which is the pain over the pubic symphysis, and the iliac crest apophysitis that we tend to see a lot. Here are some red flags that we have to look at and rule out. Once you start having night pain, unexpected weight loss, I think Dr. Pollyanna alluded to this, neurological deficits, we have losing sensation, losing strength, reflexes are going balanced, you want to investigate. But for today, we're going to talk about chronic pain without talking about the red flags. So what is chronic pain? Again, I'm glad you asked. So it's pain that persists greater than 3 months or beyond expected tissue healing. Notice, beyond expected tissue healing, right? So persistent versus recurrent pain. So there's some nociceptive or some neuropathic and nociplastic mechanism that's going on because it's going on for so long. Of course, there's sport specific pain during performance, meaning chronic pain only when they're performing, or chronic pain at rest. So let's look at some of the common presentations. So in common sites, lower back pain, pain around the knee, patellofemoral syndrome, Achilles, tendonitis, shoulder rotator cuff, AC joint, and the elbow I mentioned before. What are the risk factors? Previous injury can be a risk factor. Training load spikes where suddenly they increase because they're coming up to champs or they're coming up to some developmental meet. Biomechanics, again, some anatomical irregularity, or just poor training biomechanics, right? Poor techniques in their training. Inadequate recovery where they're not allowing themselves to recover. And of course, psychosocial stressors, because we know that when we're under stress, we tend to be all wound up and our musculoskeletal system doesn't perform as well. And again, sport-specific patterns around the groin, the hip, shoulder, and the swimmers and throwers. Now, coming to my exciting part now, let's review pain. So pain is very complex, right? But yet simple. So nociceptive, as we know, are the nociceptive receptors, and you have the alpha, let me get my laser. You have the alpha delta fibers within the myelin neurons, which are in the periphery, and the C fibers, and they will send the impulses up to the brain. So the pathway begins as free nerve endings around the vessels, around the skin, as Alison mentioned before, in the cutaneous tissue of the muscle, and they travel to the dorsal horn, dorsal root ganglion, the DRG, in the spinal cord, and then those are the first order neurons, the one from the periphery. Then they connect with the second order neurons. I'm going to have a picture afterwards. And those second order neurons will then go up to, so you have the skin, you have the first order neurons, they go up through, this is the DRG, dorsal root ganglion, it's a bipolar nerve, it's a sensory nerve, as opposed to the anterior horn cell, which would be here, which is a motor nerve. All right, so this is the dorsal root ganglion, and it synapses with the second order interneuron, which goes to the thalamus, and then the third order, which will take the pain sensation from the thalamus to the somatosensory, this is supposed to be sensory, but I like this diagram, even though sensory is spelled correctly, to the pain strip, the pain motor strip in the brain. So there are 3 neuron relay systems that can pick up pain, temperature, and touch. So let's talk about what happens when you have pain. So pain is an unmet medical need. Pain is good because pain tells you something is going on, but pain is bad because it can make your life miserable. But it is still good because without pain, we might hurt ourselves. So 1 in 8 of you will experience poorly relieved persistent pain at some point in your life, right? Only 50% of patients post-operatively pain is satisfactorily controlled by therapy, right? So chronic unrelieved pain produces a disease state with its progressive, with its physical stress on the body, social discomfort, and I should add psychological issues as well. So reduction in sports performance will occur with our athlete, their quality of life, they will end up going on to depression. There's a heavy medical burden on their team because the team always have to send them to the physio or to the doctor. There's a social economic burden for the parents as well who are paying for their medical care. poor choices of effective and safe analgesic. Because they're in chronic pain, they start taking all sorts of stuff. They start going anywhere for treatment just to get the pain under control. So the two main classes of analgesics that we're going to talk about is the opioids and the anti-inflammatory. And they were discovered years ago. So 400 years ago, Rene Descartes discovered the pain transmission. The flame that burns the hand is transmitted along the nervous system. So imagine you have a flame and it's burning your foot and it goes up through those first order neurons up to the spinal cord. So that's a noxious stimulus. Then you activate the nociceptive in the skin, or you have some nociceptors within the muscle mechanoreceptors. You have nociceptors all over. But say we're talking about the ones in the skin. And then it's transmitted to the brain through the second order neuron. That's the thalamus. And then, of course, to the third order neuron. And then you perceive pain in the somatosensory area, right? Well, it's not that simple. Well, now I'm going to tell you why it's not that simple. There is a complex interplay with different neurons that should not transmit pain that overlap with pain transmission during a process of chronic pain. I'm going to say that one more time. Pain transmission is usually through the pain fibers, right? However, when you have chronic pain going on for a long time, you get an overlap and cross reaction, almost like a short circuit in some cases, and in other cases, you have upregulation, and there are different types of upregulation. So again, these are the different fibers that will transmit into the spinal cord. Again, remember the dorsal root ganglion, this is always sensory, a bipolar nerve, this is a motor neuron, and this is the first order, we'll send it up to the second order, and it goes up to the brain. So where is my thing to continue? All right, so there you go. So we proceed. Why am I not moving? My slideshow is stuck. I'm going to end and resume. I'm going to start again because I'm not so sure what happened. All right, so let's go back one. All right, so we just saw that one. Okay, so what are the mechanisms? So you have peripheral nociception, which is an ongoing tissue pathology or inflammation. So for example, I pinch you, and I pinch you for 1 year. So if I pinch you for a year and I stop pinching you, two things can happen, of many. One, you will still feel the pinch because I've now created a footprint in the brain. Or two, when I go to gently touch you in that area, you perceive pain. Let's find out why that happens. So you have peripheral and central sensitization. So you get hyperalgesia, allodynia, cortical reorganization. I'm going to talk about those individual. You get nociplastic neuroplasticity, where you have new neuronal channels that are formed. And so you will end up having disproportionate pain without clear structural correlation or clear inciting or noxious stimulus. And of course, there's the psychosocial contributors, the fear of avoidance that interplays, catastrophizing. People say, oh my God, I'm in pain. If I feel a little pain in my foot, because it's been going on so long, it's more serious than they think it is. Then it might affect their sleep. And you need sleep to be able to control your anxiety. And you need sleep for healing of your tissue. It affects your mood. Again, social and financial pressures occur. So chronic pain, usually located in the soft tissue rather than in the joints, and it's poorly localized. So you get allodynia. Remember I told you allodynia? So allodynia is a non-painful stimulus that elicits a pain response. Different from hyperalgesia, where you get increased response to a stimulus that's supposed to cause pain. So for example, if I pinch you, it's supposed to hurt. But when you have hyperalgesia, when I pinch you, you're like, oh my God. So for example, I think I had radicular pain in my right foot. If I bump my right toe, my goodness, it's so painful because I think I have hyperalgesia. But if I bump my left foot, it doesn't hurt because I've been ignoring my back pain. Maybe I should come to one of the therapists for my sciatica, right? Physician, heal thyself. You can also get secondary hyperalgesia. What does that even mean? So it's expansion of the pain to areas outside of the original injury site. So I pinch you on your left forearm for a year, and now you start having pain on your right forearm or in your hand or up in your shoulder or somewhere else. you have this thing called cutaneous allodynia, where you get convergence. So cutaneous sensory neurons, they tend to kind of overlap, and you have the pain pathway converging to the nociceptive pathway. And so this helps to explain cutaneous allodynia. But you also have muscle hyperalgesia, where you have the mechanoreceptors. What will happen is movement, which is to be picked up by mechanoreceptors. Those mechanoreceptors kind of overlap, and they are now being transmitted with the nociceptors, for want of a better description. So movement, but not only is it muscular, you can get mood, you can get temperature, you can get light touch, you can get emotion, the parasympathetic system. So all of those neuronals, they kind of converge on the nociceptors, and they cause pain. So like when people are sad, it stimulates the pain. When they move their knee or something, it causes pain. So what's happening here? Hyperexcitability. So you have this nociception, this sustained nociceptive input. Remember, I'm pinching you for a year. It causes excitability in the brain, and so there is pain. So let's talk a little bit about that specifically now. Neuroplasticity. So sensitization of the nervous system occurs as a result of neuroplastic changes at multiple levels in the brain. So as you guys know, neuroplasticity, back in the day when I did medicine, once you have a stroke, you have a stroke. Once you have a nerve injury, you have a nerve injury. Well, at least in the brain and the central nervous system. But now we know that there's neuronal regeneration. There's collateral sprouting, right? And there are all different types of neuroplastic pathway that's going on. So you get this thing called a wind-up, different from, well, let's explain temporal summation. So wind-up is a temporal summation. What do I mean by that? So progressive increase in your pain from repetitive mechanical stimulus. I'm touching you, touching you, touching you. And instead of, if I hurt you, you're supposed, and I stop hurting you, the hurt is supposed to subside, or the pain is supposed to subside, and then I hurt you again, and the pain goes up. But in wind up, what happens is the pain doesn't go back to baseline. So there's a summation, a temporal summation. So it keeps adding up, adding up, adding up, and it never comes back to baseline. So there's augmented temporal summation and delayed decay. So the second pain, it doesn't go down. So you keep getting more and more pain added on to the pain. So it occurs as a result of high frequency repetitive discharge of these nociceptors. Now, there's another thing called central sensitization, which is a little bit different. Which is a little bit different than the wind up. The hyperexcitable state, everybody's okay? The hyperexcitable state of the second order neuron. You remember the second order neuron, which is this one in the middle, the one that starts in the spinal cord after the first order neuron from the dorsal root ganglion. This is the one that takes the information all the way up to the thalamus, right? So pain signal in that second order neuron is amplified. So firing more frequently with higher intensity, even when the incoming signal from the first order is not all that, right? And so this is different from wind up. So wind up is where there's a buildup and it doesn't go back to rest. There's a buildup and it doesn't go back to rest. Whereas this is just hyper sensitization. There's a upregulation. So the pain is stimulated. So how does that happen? So there is a complex interplay between cellular, structural, and chemical alteration in the dorsal horn neuron. That's the DRG right there in the spinal cord. So normally, NMDA, as you guys know, is our receptors in the second order neuron that they block magnesium, and this kind of controls transmission. But with repetitive input from these peripheral C fibers, there is release of neurotransmitter. You get release of neurotransmitter like glutamate and substance P, and leading to strong depolarization. That means more action potential being sent, and it kicks out the magnesium. So more pain perception is transmitted up through the spinal cord to the thalamus and then to the sensory cortex. There's also reduced inhibitory controls. As you guys know, GABA and glycine are what will kind of quiet things down, reduce neuronal excitability, and maintain some balance. Whereas in central sensitization, there's a reduction in the reducing or the neurotransmitters that regulate, right? So there's a reduction in those. So how do you assess these patients? Of course, you must have focal assessment. Focus assessment, sorry. So you want to get a good history, onset, pain behavior. Is this person a secondary, looking for secondary gain? I don't like to use the word malingering, but you have patients who have, and athletes that have secondary gain from their parents. They don't want to play sports or they want more attention. You want to look at load relationship, meaning how does the pain come on with loading? And of course, you want to maintain red flags. And if there's a red flag, you want to, okay, this is a little bit more than chronic pain. This is a true pathology that needs to be investigated. So you want to determine the pain characteristic, the location, the quality, the temporal profile. Is it there all the time? Is it, does it get worse? Or is there something that aggravating factors, provocative factors, or something that relieve it, right? You want to do functional assessment specific to the sports. You want to check their strength, the range of motion, movement, kind of similar to with the myofascial pain. And of course, as Dr. Paliana would have mentioned, that there are some different screening metrics that you can use. These are some that I'm going to mention: the TAMPO, kinesiophobia, the PCS, and some other sleep ones. And of course, there might be some pain mapping. And so here's an example. I'm just putting them out because I'm not a this kind of pain specialist, but this is an example of the Tampa scale where you're asking, am I afraid of what I might injure myself if I exercise? And then you want to ask patient health questionnaire, little interest in pleasure in doing things. And of course, this is an example of pain mapping. Now, the role of imaging, who and when do we image? Well, indications are important. One very significant indication for imaging is new worsening deficit, loss of strength, loss of sensation, loss of reflexes, declining function. If you suspect a fracture or an infection, failed conservative care with functional impairments, then you want to do some form of investigation. Now, there's a high prevalence of incidental findings in an athlete. So I remember when I first started sports medicine, we were doing an MRI on somebody's ankle, and I didn't know that most athletes will have bone edema. Most athletes will have bone edema. And I saw the MRI and I was like, oh my God, the person has a stress fracture. And then over the years, when I was in Germany, one of our athletes had knee pain and there was edema in the femur. And I'm like, oh my God, there's edema in the femur. And they're like, a lot of athletes will have these changes on MRI, but you have to correlate it with their clinical presentation. So you're going to find things if you're ordering an MRI that you're not looking for, right? Incidentaloma. But MRI is usually very useful if you're looking at soft tissue or cartilage. You want to do MRI angiogram if you're looking at the cartilage, which is the labrum or the labral in the shoulder or in the hip. Ultrasound if you want to look at tendinopathy. Why ultrasound? Because ultrasound is dynamic. You can look at how the tendon moves, especially around the acromion. CT for bone details, nerve conduction study, especially if you start looking at sensory, common peroneal nerve, tarsal tunnel syndrome. These are things around the ankle, right? Or even radiculopathy as it relates to pinched nerve in the back. So non-pharmacological management, what do? You want to load them progressively. So you don't want to jump back into the whatever it is that they used to do. You want to progressively load them. So everybody's body is different. So it's individualized loading, modified training rather than complete. Put them in the water, let them run if it's a chronic thing at the ankle. We want to still ensure that they have their endurance, because if it's a professional athlete or a lot of our high school athletes, there's a lot of pressure on them to compete with champs. And, fitness will go down if you don't continue to train. So you can offload them. And some of our main clubs will have the unweighting system, the actual treadmill, or some people just put them in the pool with floating belts so they keep, take the pressure off, right? Exercise therapy is very important. Of course, that goes without saying. Strength, motor control, eccentric loading. I always tell people about muscles, long and strong. When I said that to Agri Irons one time, he's like, be careful what you say. But the muscles must be long and strong, right? Because if they're short and strong, they're going to tear, right? So graded exposure for movement, fear. So if someone is fearful of movement, you kind of help them through that. Manual therapy and adjuvant therapy. short-term relief best combined with active rehab. And you want to look at their sleep hygiene. You want to look at their nutrition. Are they eating foolishness? Like, are they only eating fast food? Do they have a balanced diet represented by all the food groups, and especially the food group that allow like fruits and vegetables for repair and protein for muscle development, right? And of course, if it's a bone, calcium, etc. So you want to have these recovery strategy that they want to go through. And of course, you have the psychological intervention. You bring on people like Nicholas and Dr. Polyan on to help us with that. And of course, the pharmacological. Now, NSAIDs, short-term use. You can use topical NSAIDs. Of course, for the chronic pain, you might need a little bit more because NSAIDs are anti-inflammatory. What does that mean? They treat inflammation. But remember, we're not treating inflammation, we're treating what? Upregulation. We're treating neuropathic, so we're going to need neuropathic agent. So we use the gabapentinoids like the gabapentin and pregabalin, and the serotonin, norepinephrine reuptake inhibitors. I'm going to tell a little bit about those for neuropathic pain, but we use them cautiously and you have to monitor them. Of course, you have local injection, corticosteroid short-term use. PRP can be used sometimes, helpful in some tendinopathies. And of course, you can have anesthetics or tendinotomy procedures, right? You have neuromodulation intervention. So you can have pulse radiofrequency peripheral nerve stimulators. I mean, I've had, well, not for athletes, but I've had patients where they put in spinal cord stimulator, which is they put the electrodes in the spine on top of the spinal cord to kind of short circuit the pain sensation or the pain signal that are going up to the brain. So it kind of abates the signal going to the brain, so pain is not perceived. And you want to avoid opioids prescribing if you're dealing with chronic. I suppose I didn't take out this slide for chronic cancer and athletic pain, right? So you want to make sure that you're not giving the athletes too many opioids, because opioids, as you know, are banned by World Anti-Doping. So I mentioned steroid. Of course, you can use steroid. Since 2024, you can use steroid, but there must be a washout period. And the washout period is determined by the route. Orally, it must be 3 days. If it's a glucocorticoid before therapy, you have some other like triamcinolone, triamdenc is 10 days. So intramuscular, local injection, rectally, there are different washout period before you compete. You can actually use steroid, right? So again, the red flag, you want to differentiate unresolved structural pathology, labral tears, stress fracture, those are red flags. Tendinopathy versus neuropathy versus referred pain, like something from a herniated disc referring down the leg. You want to make sure you're not missing something, right? And unexplained systemic symptoms like chronic fatigue, fever, malaise, swelling, all different stuff that you can get. You want to look for progressive neurological deficit, as I mentioned, night pain, unrelieved by changing position. And if you're suspicious of a fracture or infection, or that might be malignant, because remember, athletes can get malignancy too. Sometimes they've had athletes that have breast cancer and with some axillary node involvement. Now, the question is return to play. When do you return to play? Of course, it must be staged, and it's criteria-based process. So symptom control, what does that mean? You go along how you feel, right? So if they have severe pain, of course you have to pull back. If they don't have pain, you can gradually progress them to the type of sport that they're doing. So progressive exposure, objective strength and movement benchmark. You want to do that. You want to do sport specific skill. So if it's football, you want to make them cut from left to right, right? If it's jumping, you want to simulate jumping. Of course, if it's patellofemoral syndrome, you want to gradually get them into the plyos before you send them out to start jumping. Of course, you want to make sure they're psychologically ready, because sometimes if they're physically ready and they're not psychologically ready, they're going to implode and they won't perform. And then you want to sometimes use performance matrix, which are quantitative and data-driven measures used to assess physical, technical, or tactical ability of each of the athletes. And of course, it's a shared decision with the athletes, the coach, and the parents, if we're dealing with young athletes, and the team. And this accounts for season timing. So are we going to start if you're going to peak for world championships in August, July, or if we're dealing with high school, they usually go back to school in September. Do we hold you back and not start training until like November because champs, or January even because champs is in March. There are different tactical things you'll do to control the pain. Pain meds, of course, globaljoe.org. You can go and check your medication. Again, you may need to use neuropathic pain meds in athletes. And interestingly, all of these pain meds are water approved. I actually went to look for gabapentin and pregabalin for sports like archery and for sky sport, and they were still allowed in competition. I was actually expecting them to say gabapentin is banned if you're going to be throwing a dart or if you're driving a race car. Because remember, we're not just only doing physical sport. I would think that if somebody's doing the pole vault, that it would be banned for gabapentin. But when I looked at globaljoe.org, it's not. And again, the reason I'm thinking is that it can make you dizzy. But of course, clinical correlation. If it said to make them dizzy and they feel off, then you either back it off or you discontinue it. So, the serotonin and norepinephrine reuptake inhibitor, Cymbalta or Effexor, the gabapentin, and the amitriptyline. I use amitriptyline, gabapentin, and pregabalin a lot. I find, this is just my anecdote, I find gabapentin works better than pregabalin in our population. When I was in America, pregabalin, which is Lyrica, worked a lot better than gabapentin. And gabapentin is the cheap because gabapentin is much cheaper than pregabalin, which is Lyrica. And of course, pregabalin, you have Neurobalin, and you have Nervigen P, and you have the different ones, and you have Pregasafe is another one. So the takeaway and future direction, chronic pain in athlete is multifactorial. We want to assess the tissue. Is there something going on? Labral tear, muscle tear, tendinopathy? You want to look at the nervous system. Is there some hypersensitization that had occurred that require down regulation with neuropathic medication? Of course, you want to bring in the psychosocial the support team, the psychologist, the pain management specialist. It's multimodal loading based rehabilitation. You want to gradually build them back up. Of course, it's targeted based on the sports. And so you need more and more sports specified trials for intervention to be able to ensure that athletes are successful so that you have good long-term outcome. And of course, you want to determine if there are any biomarkers for nociplastic pain that may occur. So I had a little example, but I think I'm beyond my time. So I will just say thank you and stop sharing. And then I will listen to the question.
Thank you so much, Dr. Dawson. You have done double duty today.
God bless. God bless.
To have had you here, we have learned quite a lot. And the talks have been so interesting, we didn't even realize that we have exceeded our time.
Yes.
Any questions for Dr. Dawson from this presentation? No questions?
And the dinner time.
No questions so far.
Somebody had asked about repeating it earlier.
Excellent presentation, Dr. Dawson.
Bless you, bless you.
Okay, wonderful. All right, well, thank you, everybody. I still see that we have 85% logged in. And we have our giveaway at this time. So let's see if you're paying attention. I think our speakers are still here, so they can verify if your answers are correct. It's a two-part question. So let's start with the first one. So we have two questions. We're giving away 2 Amazon gift cards worth $30 each. And we're going to ask a two-part question for the first one and another two-part question for the second one. We're trying to cover all the talks that are here. So the first person to raise their hand or type the correct answer in the chat will get the gift card. All right, so the first question, part A. What does the red signify and what pain level is considered a red light? And this is coming from Dr. Chang's chat. Dr. Chang, you're still here, right?
I'm still here, glued in.
Is that question a good question? I want to make sure we got
It's a good question. It's speaking to the traffic light setup.
Now, if you're paying attention, all right. So Diallo,
bias.
for me, I have some persons here typing away.
Yes.
I think the first person I saw was
Tobias.
Tobias, yes.
He says 7 and up.
Is that correct, Dr. Chang?
It's actually, no, 7 is not correct. I'm gonna allow you to find the next person, but thank you so much.
Jonathan Higgs, I think.
No, 6 is not it.
Jonathan Higgs is the next person. Is that correct?
No.
No, so it's my question, which was a traffic light?
Yes.
The red is 6 and up.
6 and up. All right. All right. So anybody who's Jonathan Higgs,
So
Isha,
Jonathan Higgs.
and Isha have that first part. Now that to get the card, they still need to answer the second question. Second part of the question. What were the 4 factors that you should look at when you're making up the sport injury risk profile? I think this came from Nicholas' talk. What are the 4 areas that we're looking at? Remember, we're doing a unified approach. So Jonathan and Isha are in the running for this.
Aisha.
Aisha, sorry. You remember the 4 parameters we look at?
Jonathan says mental. 4. Any 4. Dr. Powell, you want 4?
You take mental and psychological. You still have to give us the other 3. This question harder than I thought, man.
Yes, 4 is a lot, isn't it?
All right, we'll take 2.
2?
All right, Trudy Ann.
Yes, but you're not in the running.
She's not in the running.
Type quickly, Jonathan. Type quickly, Aisha.
All right, all right.
Yeah,
So it looks like I have to give 2 gift cards. So we're gonna give Jonathan the first one and Trudy and the second one. All right, for the next gift card now. So this one is worth $40. And this one you have to get both parts right or nobody's gonna get the gift card.
Right.
All right. So for part 1, name the 2 sensory receptors that we can stimulate that gets to the brain, stimulating the skin that gets to the brain faster than pain and temperature. And this is from Allison's talk. What?
Come on, guys.
Kimali.
No, Kimali. Ramon on the right pathway. Good, Ramon has it. Part A.
Part A.
B, no.
Excellent, Ramon. And then the second question comes from Dr. Dawson's talk, Ramon. So take it home for the prize. List 2 clinical sites that we assess for myofascial pain. So Trudian is in the running too, you know.
Trudian has a misspelling.
Oh, that's true. Trudian spelling counts. Oh, fast typing. Yes, I understand. I can't type fast either, you know. Come on, don't remember.
Man does not remember.
No.
To answer the question in full then, those who are answering, put in for part A and part B.
You have gotten a part of the answer. So the first question was the 2 sensory receptors that we can stimulate. That gets to the brain, stimulating the skin, that gets to the brain faster than pain and temperature. And the answer was correct. But part B now was list 2 common clinical sites that we assess for myofascial pain. And Dr. Dawson, please check and see if these answers are correct.
Okay, I'm looking in the chat.
You have to retype quickly.
Oh, you said 2?
Yes.
You need to
So
retype.
Claude is kind of right-ish.
Oh, no, I'm have to get it good.
Right. Type in the 2 answers.
Okay. Yes. Kamali got
Kamali,
it.
you have to type both sections to get it.
Both sections to get the prize.
Whoever is typing both sections.
I think I can give it to Kamali because even though sternocleidomastoid isn't written, we had a picture of it at the sternocleidomastoid.
But he has to answer both parts.
Oh, the both parts. Okay.
One card. Type over, people.
You guys can share the card. Collaborate.
Type over,
$20 each.
type quickly. All right. Ramon has a complete answer.
Ramon is very smart. Ramon, you're cute.
You win the prize for being innovative
and a quick typer.
All right, so congratulations to our winners. And at this time, I'd like to thank everybody who has stayed the course with us. We started off with some technical difficulties, but we had an amazing, in my opinion, KP. I thought the speakers were excellent. I didn't even realize that the time was going by so quickly. Some of them even went over their time, but because the talk was so good, the timekeepers were not on top of their jobs because they were enjoying the talks. I'd like to thank everybody for coming out today. It's a Sunday afternoon. I know you may have other obligations, but this could not have been successful without your presence, and we really hope that you enjoyed the discourse and that the knowledge you have gained here will enhance your practice. And I also want to give a big thank you to our speakers. I approached them at short notice. Nobody said an outright no. Dr. Dawson offered to give 2 talks. Alison was traveling and she made it back in time. So I'm very grateful to our speakers. And thank you for being with us. They took time out of their busy schedules. We are not paying them. And they shared with us and stayed throughout the course today. So
we're not getting paid?
For that, thank you so much. And I also want to thank the Education Committee for all their support throughout the planning and execution process. And I also want to thank the JSM executive for helping me with this first one. We had a lot of little challenges, but it came out really great in the end. I would like to remind you to please complete the evaluation form that is in the chat. It will provide valuable feedback for us for further webinars, and also for persons requiring CMEs. Please remember to email jasmeducation@gmail.com with your proof of purchase, and we will be sending out the certificates within the next 30 days. So we look forward to seeing you at our next KP in August. Please follow us on our Instagram, Facebook, and LinkedIn profiles to keep updated. Please enjoy the rest of the evening. Be safe and have a great week. Thank you.
Thank you. Bless you all. Bless you all.
Thank you.
All right, everyone. Thank you very much. Have a good evening. Gonna close the meeting. Thank you.